Dear expert, good day. It's my great honor to present our study, Prevalence and Genotypes Analysis of Thalassemia among People of Reproductive Age in Yuzhong District of Chongqing based on next-generation sequencing. Thalassemia is a common monogenic hemolytic anemia, highly prevalent in southern China like Guangdong and Guangxi. At a southwestern city, Chongqing lacks sufficient molecular-level epidemiological data on thalassemia. Our study aimed to investigate the carrier rate and gene spectrum of thalassemia among reproductive age couples in Yuzhong District, providing evidence for local prevention. We conducted a cross-sectional study. From January to July 2019, 1,000 pre-pregnancy couples were recruited at Chongqing Maternal and Child Health Hospital. Peripheral blood samples were tested for routine blood parameter hemoglobin electrophoresis, and the next-generation sequencing, NGS, for alpha and beta globin gene mutations. Now for the key results. First, carrier rates. Total thalassemia carrier rates 7.45%. Alpha thalassemia 4.6%. Beta thalassemia 2.1%. Alpha beta compound thalassemia 0.15%. We also found 5 novel mutations in 12 cases, accounting for 0.6%. Second, the many genotypes proportions for alpha thalassemia. The top 3 genotypes accounted for 53.26%, 23.91%, and 11.96% respectively. For beta thalassemia, the top 3 genotypes accounted for 26.19%, 26.19%, and 40.29% respectively. Third, clinical highlights. 3 couples with hormone types alpha thalassemia were identified at high risk of severe thalassemia offspring. Some carriers have normal MCV, MCH, easily missed by traditional screening. This confirms NGS value for accurate detection. In conclusion, Yuzhong District is a moderately high prevalence area for thalassemia. Second, the mutation spectrum is diverse, with common Southeast Asian anemia and local level variants. Third, NGS-based pre-pregnancy screening is strongly recommended for local reproductive age couples to reduce severe thalassemia births and improve population health. Thank you all for your attention.
Ladies and gentlemen, I'm Xiaoye Yang from the Department of Obstetrics and Gynecology, Chongqing Health Center for Women and Children. It's my honor to present our retrospective study on stillbirth at the 4th International Conference on Gynecology and Obstetrics. Stillbirth is advanced pregnancy outcome, causing profound trauma to family and challenging to prenatal health care. To clarify its incidence, causes, and risk factors, we conducted this study. Method. We performed a retrospective and analysis of 324 stillbirth cases in our hospital from January 2017 to December 2023, compared with 100,016 live births in the same period. Result: first, the overall stillbirth rate was 3.2 per thousand, with no significant yearly difference. Second, we identified 3 high-risk groups: a U-shaped relationship between maternal age and stillbirth. Stillbirth risk in multiparent women was significantly higher than in primary women. The stillbirth rate in twin pregnancy reached 16 per thousand, much higher than singlets. Third, the top risk factors were maternal factors: uterine malformation 20 per thousand, several preeclampsia 13 per thousand, infection 13 per thousand, placental and umbilical cord factors, true cord knot 19%, short cord 17%, placental abruption 11%, fetal factors, twin pregnancy 17 per thousand, fetal growth restriction 11 per thousand, and congenital anomaly 5 per thousand. Advanced maternal age, multiparent, and twin pregnancy were identified as high-risk group for stillbirth. Concluding, to reduce stillbirth, we recommend 4 key strategies: strengthen preconception care and counseling, activity management pregnancy complications, improve antenatal and intrapartum monitoring, enhance midwifery and emergency skills. In summary, stillbirth prevention requires a full circle management system. We hope our data can support clinical practice and guide the development worldwide. Thank you for your attention. I welcome to comments and discussion. Thank you.
Good afternoon, everyone. My name is Wei Wang from the Chongqing Health Center for Women and Children in China. Good afternoon, everyone. My name is Wei Wang from the Chongqing Health Center for Women and Children in China. Today, I'm excited to present our study titled Predictive Effect of Fasting Blood Glucose During Pregnancy on the Occurrence of Gestational Diabetes Mellitus and its relationship with adverse pregnancy outcomes. The objective of our study was twofold. First, to evaluate the predictive value of fasting blood glucose, both before pregnancy and in early pregnancy, for the development of gestational diabetes mellitus, hereinafter referred to as GDM, and second, to explore its relationship with adverse pregnancy outcomes. We also aimed to identify a relatively safe fasting glucose threshold in the preconception and early pregnancy periods to help prevent and manage GDM. We conducted a prospective cohort study. A total of 565 women who underwent pre-pregnancy physical examination and became pregnant within 6 months after the examination were enrolled at our hospital between January 2020 and January 2021. All participants received standard preconception evaluations, including a fasting plasma glucose test. Based on their preconception fasting plasma glucose levels, they were divided into 2 groups. Low-level group, fasting plasma glucose between 3.9 and 5, high-level group. Fasting plasma glucose between 5 and 6.1. At 10 to 12 weeks of gestation, we measured early pregnancy fasting plasma glucose and further divided the women into low early pregnancy fasting plasma glucose group 3.9 to 4.5, high early pregnancy fasting plasma glucose group 4.5 to 5.1. An OGTT test was performed at 24 to 28 weeks of gestation. They were divided into GDM group and normal gestational blood glucose group. We compared preconception fasting plasma glucose levels between the two groups, determined a threshold for predicting GDM, analyzed the relationship between preconception and early pregnancy fasting plasma glucose, and compared the difference of adverse pregnancy outcomes between different pre-pregnancy and early pregnancy fasting plasma glucose. Our main findings are as follows. First, a preconception BMI of 24 or higher, a preconception fasting plasma glucose of 4.95 or above, and a family history of diabetes were all significant risk factors for developing GDM. Second, women with higher preconception fasting plasma glucose also had significantly higher early pregnancy fasting plasma glucose levels. Third, when preconception fasting plasma glucose reached 4.95 or higher, the risk of later developing GDM increased significantly. This threshold may serve as an early warning indicator, and also when preconception fasting plasma glucose reached 5 or higher before pregnancy, or fasting plasma glucose was above 4.5 during early pregnancy, the incidence of adverse pregnancy outcomes during pregnancy was increased, including spontaneous abortion, stillbirth, premature delivery, macrosomia, and no birth weight infants, and all the differences were statistically significant. In conclusion, our prospective cohort study demonstrates that enough attention should be paid when fasting plasma glucose was above 4.95 or higher before pregnancy, or was above 4.5 during early pregnancy. An intervention should be given if necessary to prevent and control the occurrence of GDM and reduce the influence of GDM on maternal and perinatal health. Of course, further large-scale studies are needed to validate these findings of this study. Thank you for your attention.
It's my honor to present our study. Our purpose is to analyze the effect of the choice of timing of cervical cerclage treatment on pregnancy outcome in pregnant women with cervical insufficiency. Our methods, the case data of 116 pregnant women admitted to our hospital for cervical cerclage due to CI from January 2020 to September 2021 were sampled. They were divided into the early group, 14 to 18 weeks of pregnancy, and equals 18.6. The middle group, 19 to 27 weeks of pregnancy, and equals 17.4. According to the different gestational periods of surgical treatment, and into the elective group, elective operation, and equals 17.1, and the emergency group, emergency operation, equals 18 line, according to the different times of surgical treatment, to compare the pregnancy outcomes of the 4 groups and the effects of different treatment timing on pregnant women and newborns. About our results, there are 7 figures. Look at the figure 1. The intrauterine infection rate in the early group was lower than that in the middle group. It's 8.14% vs 71.62%, and the intrauterine infection rate in the elective group was lower than that in the emergency group. It's 18.31% vs 61.8%, p less than 0.05. Look at the figure 2. After the operation, the late abortion rate in the early group was 8.14%, lower than 63.51% in the middle group, and the late abortion rate in the elective group was 15.49%, lower than 61.8% in the emergency group, p less than 0.05. Look at the figure 3. The full-term birth rate in the early group was higher than that in the middle group, and the full-term birth rate of the elective group was higher than that in the emergency group, p less than 0.05. Look at the figure 4. There was no significant difference in the preterm birth rate between the early group and the middle group, and between the elective group and the emergency group, p larger than 0.05. Look at the figure 5. There was no significant difference in neonatal APGAR score between the early group and the middle group scores, and between the selective group and the emergency group scores, p larger than 0.05. Look at the figure 6. There was no significant difference in gestational weeks extension in time between the early group and the middle group, and between the elective group and the emergency group, p larger than 0.05. Look at the following figure. The length of hospital stay in the early group is shorter than the middle group, p less than 0.05, and the length of hospital stay in the elective group is shorter than the emergency group, p less than 0.05. So our conclusion is the therapeutic effect and pregnancy outcome of cervical cerclage are affected by the timing of treatment. Among them, the effect and of elective operation and 14 to 18 weeks of pregnancy is more ideal, which is worthy of clinical promotion. Thank you.
I am Dr. Shamsun Nahar Shopna from Bangladesh. I'm working at Government Hospital, Railway General Hospital, Dhaka. First of all, I will give my gratitude and thanks to you, Scientex Gynecological Conference Society, who inviting me and accept my topics to present here on efficacy of a single 5,000 international unit dose of HCG in enhancing pregnancy outcomes. This is my presentation outline. The clinical challenge is early pregnancy loss. It is the nightmare for some couple who gone through this condition. For this reason, I have chosen these topics. 10 to 15% of clinically recovered pregnancy are end in loss, and at first trimester, most critical and vulnerable developmental window. NNT is equals to 7. Women treated to prevent 1 miscarriage. Why this period matters? Implantation, placentation, and organogenesis all occur in the first trimester. Adequate HCG and progesterone are critical hormonal pillars of early pregnancy. Low endogenous HCG correlates strongly with pregnancy failure. Research gap: meta-analysis support HCG use, but findings remain mixed. Optimal dosing, timing, and patient selection are undefined. According to SCOG, HCG is not definitively proven for preventing early loss. Rigorously designed prospective trials are urgently needed. Key physiological role of human gonadotropin, that is HCG. First of all, corpus luteum support maintains progesterone secretion, preventing luteal phase defect and supporting pregnancy continuation. Implantation failure supports endometrial receptivity and trophoblast invasion at the implantation site. Immunomodulation promotes maternal fetal tolerance via effects on uterine natural killer cells and cytokine expression. Pregnancy viability marker: beta HCG doubling patterns are reliable predictors of viable ongoing pregnancy. Key rationale: women with early complications show significantly lower endogenous HCG compared to normal pregnancy. This is from Condoms et al. 2003. Efficacy of a single 5,000 international unit HCG dose in early pregnancy. Now I'm telling about the study objectives. Primary objectives: assess whether a single 5,000 international unit IM HCG injection improves ongoing pregnancy rates in women at 6 weeks gestational age with no cardiac pulsation, but her serum beta HCG level shows positive result. Hormonal objective: evaluate biochemical impact on beta HCG more than 1,500 IU per liter and progesterone more than 10 nanogram per ml level at day 5 post-injection. Viability objective: determine fetal cardiac pulsation detection rates at 8 weeks gestation between HCG treated and control groups. Safety objective: document rate of threatened abortion and adverse events to establish a risk-benefit profile for routine HCG supplementation. Study design and protocol. Now I'm telling about the methodology. Study parameters: study type, prospective comparative study RCT design, that is randomized control trial design. Setting at Salahuddin Specialized Hospital, Dhaka, Bangladesh. Duration from January 2023 to January 2024. Sample size was about 120 pregnant women, 60 in each group, A and B group. Inclusion criteria was 6 weeks gestation with no cardiac pulsation, but their serum progesterone level was positive. Analysis by SPSS B26 chi-square test, Pearson correlation. Randomization follow: 120 eligible women enrolled, randomized 1:1. Group A, that is HCG injection given at about 60 women, and Group B, standard care, that they are controlled. Outcome measure: day 5 hormonal level done, and at 8 weeks fetal heartbeat seen, and term there is live birth. Participation profiles: group were well matched at baseline. These are the data at age 20 to 30 years, 38% in group A, that is who received HCG injection, and in group B, 35%, around 58.3%. P value is at 0.56. age 31 to 40 years, 22 in group A and 25 at group B. BMI, nulliparity, multiparity, history of miscarriage, spotting in early weeks, progesterone level, gestational age. These are the my characteristics of methodology in baseline. These are the baseline characteristics. In case of nulliparous, 25 in group A and 27 in group B, that is control group, and multiparous 35 and control B, there is 33. Spotting in early weeks in group A, 8 and control group 10, that is 16.7%. Progesterone less than 10 nanogram per ml, 25% in group A and in group B, 28.3%. Gestational is less than 6 weeks, 53.3%, and in group B, 50%. HCG significantly improved all primary outcome measures. The key findings: primary pregnancy outcomes. This shows that ongoing pregnancy is higher in HCG group, about 86.7%, and in control group 70.7%. Fetal heart rate at 8 weeks found in HCG group 83.3%, and in control group 66.7%. About live birth in HCG group 78% and control group 60%. And threatened abortion was less in HCG group, that is 10%, and in control group 23.3%. Miscarriage rate also lower in HCG group, and in control group it is 30%. This is the main theme, what is I want to show. Hormonal response day 5 post injection. In HCG administration produced superior biochemical support. In HCG group, the 91.7%, the beta HCG level at serum found more than 1,500 international unit, and in control group beta HCG more than 1,500 international unit per liter is about 71.7%. That is, those who are receiving HCG from outside, that is intramuscular HCG injection, they are beneficial. In case of progesterone level, those who receive beta HCG injection, their progesterone level was more than 10 nanogram per ml. It is about 83.3%, and in control group, those who receive not receive HCG injection, their progesterone level more than 10 nanogram per ml, about 65.0%. Beta HCG difference P 0.01, that is highly significant. Progesterone difference P 0.020, 0.02, it is significant. Correlation between HCG use and clinical outcome. Progesterone level moderately positive, live birth at term moderately positive, ongoing pregnancy weakly positive, and heartbeat at 8 weeks weak positive, and miscarriage weak negative. All outcome favors HCG supplementation. Ongoing pregnancy in HCG group 86.7%, control group 70%, that is p-value 0.03. HCG significantly improves continuation. Fetal heartbeat at rate of at 8 weeks, HCG group 83.3% and control group 66.7%, and p-value 0.04. HCG increases early fetal viability. Live birth rate 78.3% in HCG group and control group 60%. P-value 0.033. HCG group's ultimate in reproductive success. Threatened abortion In HCG group, 10.0 p-value 0.05. Reduced complication in HCG group. Miscarriage rate 13.3% in HCG group and control group 30.0%. 0.03 p-value. 16.7% absolute risk reduction. With HCG more than 1,500 international unit per liter. In HCG group, we see 91.7% achievement, and in control group 71.7%. P-value 0.01. Enhanced biochemical hormonal support. Progesterone more than 10 nanogram per ml. In HCG group, we have seen that it is raised in 83.3%, and in control group 65.0%. P-value 0.02%. Superior luteal support maintained. Contextualizing findings within existing literature. Proposed protective mechanism, corpus luteum preservation, sustained progesterone secretion, 91.7% achieved beta HCG level, more than 1500 international unit per liter, direct luteal support confirmed. Enhance implantation quality and placental development, immunomodulation at the maternal-fetal interface, improved uterine cytokines expression and vascular morphogenesis. Literature alignment and divergence at Morley et al. Cochrane 2013. Meta-analysis supports HCG benefit. Our 16.7% absolute reduction in miscarriage closely aligns with reported in NT data. Raya et al. 2023 identified early beta HCG as a strong IVF predictor, consistent with 91.7% threshold achievement in our cohort. Winby et al. 1994 emphasized personalized HCG protocols. Our inclusive design broadly extends applicability. HCG guidelines cautious stance challenged by our rigorous prospective RCT design and consistent multi-outcome significance. Study limitation and methodological consideration. Single center design conducted exclusively at Salahuddin Specialized Hospital, Dhaka, restricts generalizability to the diverse population and healthcare context. It is a multi-center replication required. Sample size constraints, rare adverse events or clinically relevant 500 recommended. Absence of long-term neonatal data, neonatal outcome, developmental milestones, and infant health beyond live birth were not assessed in this study. Follow-up studies with neonatal tracking needed. Single dose protocol. Only 5,000 international units single IM injection evaluated. Comparative dosing regimen and combination therapies remain unexplored. Dose findings and combination trials needed. What this evidence tells us? This is my conclusion. 16.7% absolute miscarriage reduction by giving HCG injection. Clinically meaningful benefit comparable to previous meta-analytic entity data. That is 13.3% versus 30%, p-value 0.03. 86.7% ongoing pregnancy rate versus 70% in control. P-value is about 0.03. Single dose HCG significantly improves pregnancy continuation. 78.3% live birth rate versus 60.0% in control. P-value about 0.03. Benefit extends beyond early pregnancy to ultimate reproductive success. Superior hormonal profile achieved. 91.7% beta HCG more than 1500 international unit per liter, and 83.3% progesterone more than 10 nanogram per ml confirms robust luteal support. Clinical recommendation: HCG shows a favorable risk-benefit profile. Multicenter RCTs and dosing studies are urgently needed for guideline update. Future research direction: translating evidence into clinical practice. Next step: multicenter RCTs, that is more than 500 across diverse clinical setting in Bangladesh and South Asia for robust generalizable evidence. Dose optimization: compare 2500 versus 5000 versus 10,000 international unit, single versus repeated dose across different gestational windows. Combination therapy: HCG and progesterone supplementation versus HCG alone. Evaluate synergistic effect in high risk cohorts. Long-term follow-up: neonatal outcomes, developmental milestones, and infant health through at least 12 months post-delivery. Biomarker profiling: identify optimal subpopulation using baseline beta-HCG, doubling, kinetics, progesterone level, and immune marker. Thank you all for listening me, and thanks again.
Good morning to all again. I'm Dr. Sandhya. I'm going to share my experience about one of the catastrophic obstetric emergencies which I experienced at Castle Street Hospital, Sri Lanka during my registrar period. This is about spontaneous liver rupture associated with HELLP syndrome. Actually, this case already submitted at Sri Lanka Journal of Obs and Gynae in 2025. Can you see my slides? Yeah. This spontaneous hepatic rupture is a rare complication, occurs especially in the background of severe preeclampsia and HELLP syndrome. The estimated incidence around 1 in 4,500,000 to 225,000 pregnancies, which is quite rare. The HELLP syndrome is a severe form of preeclampsia, which can characterize by hemolysis, elevated liver enzyme, mainly AST and ALT, and the low platelet count, which can give rise to significant maternal and fetal morbidity and also the mortality. In other aspect, which can give rise to complications such as disseminated intravascular coagulation, renal failure, placenta abruption, and hepatic rupture also. So here, the hepatic rupture is one of the rarest and most fatal complication of HELLP syndrome. So my objective of these presentations are present this rare catastrophic obstetric case and discuss the clinical presentation and the diagnosis, review the management challenges, and highlight the importance of MDT care. Finally, I want to improve awareness among healthcare professionals about these rare complications of HELLP syndrome. Our patient was a 45-year-old subfertile prime gravida who was treated and investigated for primary subfertility around 15 years. However, fortunately, finally she conceived with in vitro fertilization using donor embryo. She conceived with dichorionic diamniotic pregnancy altogether, which was high-risk pregnancy, and later she developed hypertensive disorders also. So because of these multiple risk factors, she was cared at a tertiary care unit with the involvement of obstetric team, medical team, and time to time cardiology review also. She was diagnosed with pregnancy-induced hypertension at around 20 weeks of gestation. Since then, she had regular antenatal follow-up. With respect to this hypertensive disorder in pregnancy, she was followed up at both medical team and the obstetric team. She was advised about the effect of pregnancy-induced hypertension on her pregnancy and also the fetuses, and given information regarding importance of blood pressure management and also the compliance on antihypertensives also. She was well aware about the symptoms and signs of preeclampsia also. She was admitted at 32 plus 4 weeks of gestation with the symptoms of preeclampsia. Despite of good understanding and knowledge about this condition, anyhow, she was in home with these severe symptoms such as severe headache, visual disturbances, vomiting, and abdominal pain for 3 days. Finally, after 3 days, she admitted to the hospital with severe hypertension, where the blood pressure was around 200 by 100 millimeter mercury, and symptoms of preeclampsia. So, initial management for this high risk condition was done at the ICU with multidisciplinary team involvement. During the course of treatment for the high blood pressure, she was admitted for this ICU, and intravenous antihypertensive was started, and all the bloods and urine investigation was sent, and maternal and fetal monitoring was started, and continuous fetal monitoring also started. At the admission, both fetuses were live. There were no any features of intra-abdominal fluid collection, and also the evidence of placenta abruption sonographically. After admission, on top of magnesium sulfate infusion, she developed eclamptic fits, and her blood urine output was suboptimal, less than 0.5 milliliter per kilogram per minute. And finally, we got her liver function test and the full blood count, which shows although initial hemoglobin 11.8 and the platelet count 129, AST/ALT was more than 500. However, renal function was normal at the time of admission. So these 2 a.m. investigation are the only investigation we had at the time of the decision. So with the presence of these eclamptic symptoms and possible acute kidney injury due to low urine output and the HELLP syndrome, we were in a situation to stabilize this woman by controlling her blood pressure and preparing to cesarean delivery. However, nearly around 30 to 90 minutes of time after admission, found to have difficulty in monitoring the one fetus's heart sound. Then there we did the ultrasound scan, found to have single fetal demise and the bradycardia in the other twin. On that occasion, found to have significant amount of prefluid in the abdomen, but it is very difficult to identify whether it is due to placenta abruption or prefluid within the peritoneal cavity. However, with the suspect of placenta abruption, emergency category 1 cesarean section was made. During the cesarean section, just after the entering into peritoneal cavity, massive hemoperitoneum identified, around 1 liter of blood. However, the cesarean section was continued. 2 fetuses was delivered. 1 fetus, there were no any signs of life at the birth. Other fetus handed over to the neonatal team. After delivery of the placenta, we were quite try to find the evidence of placenta abruption, but we couldn't find any evidence of placenta abruption. So just after finishing the suturing of the uterus, there was a active bleeding coming from the upper abdomen. So the suspicion of hepatic rupture was there with the surgeons at the time of the surgery, and they were summoned surgical team, and Surgical team convert this suprapubic transverse incision extended into midline incision to examine the abdominal cavity properly. There we could identify this laceration of the right lobe of liver. And this was a large hematoma involving right lobe of liver, including with active bleeding. So in this time, the patient was quite unstable with the bleeding and the hypotension. So their correction of her hemodynamic status was started with the help of blood bank and the hematologist and also the transfusion physician. However, we couldn't control the bleeding. The only possible thing was to do the liver packing to control the bleeding, and by packing the liver done by the surgical team, and the 2 large passive drain was inserted to the peritoneal cavity, and patient was transferred to ICU for the stabilization and the further management. So in the second day, these are the investigation we got at the end of the second day. Her AST/ALT level was markedly increased and also the serum creatinine and potassium. Despite of blood transfusion and the correction of her clotting profile, we couldn't achieve stable hemoglobin level. So the suspicion of intra-abdominal bleeding was on the mind of the teams attending to the managing of the patient. So the ultrasound scan done, and there was a continuous drain from this drain tube. So again, relaparotomy was done at the ICU. They are found to have the bleeding at liver laceration site, but it was amenable to repair according to the gastroenterology team and also the surgical team. So again, the liver packing was done. However, in this condition, liver function and also the renal function was deteriorated day by day. And after day 3 of post-operative day 3, the patient was expired, unfortunately. So this is the post-mortem finding of necrosed liver, which involving both right lobe and the left lobe. These are the necrosed particles of the liver. So while going to pathophysiology of hepatic rupture, it's mainly occur in the endothelial dysfunction, which is the basic pathophysiology of the hypertensive disorder in pregnancy. And this endothelial dysfunction give rise to fibrin deposition. Those will accumulate in hepatic sinusoids, obstructing the blood flow. Then ischemia and necrosis will happen, reducing the blood supply, causing localized tissue death, leading to subscapular hematoma formation. Finally, this hematoma will rupture and result in catastrophic bleeding. Here, the diagnosis challenges. Most of the time, this hepatic rupture is challenging and also difficult. It's mainly because of rare incidence. And also most of the time it would have non-specific presentation, overlap with common obstetric symptoms. When it is associated with preeclampsia and preeclampsia on top of HELLP syndrome, it is very difficult to predict, especially. The warning symptoms are epigastric pain, the right upper quadrant pain, shoulder tip pain, hemodynamic instability. And this patient initially present with epigastric pain and right upper quadrant pain. But on examination, there were no tenderness, but within 30 to 90 minutes of time, she was deteriorated. However, the cause would be there for nearly 3-4 days. Anyhow, after evaluation of this maternal death, there was some delay in seeking of these medical advices. So the imaging modalities we can use for the diagnosis of liver rupture, ultrasound would be first line screening tool, as we can arrange it in the bedside also. CT scan would be gold standard for unstable patient. To arrange although the MRI scan better to identify those hematoma and bleeding, it would be not suitable for unstable patient. It would be suitable for stable patient. So most of the time, CT scan would be better in the unstable patient like this patient. So management, it almost always multidisciplinary approach with the involvement of obstetric team, general surgeons, anesthetists, hematology team, intensivists, and neonatal team, and also the gastroenterology, liver specialist or gastroenterology team. And it would be supported by the blood bank for the correction of hemodynamical instability. Regarding the treatment principles, the key management priorities are maternal stabilization. Before the delivery and the surgery, we need to stabilize the mother in case of hypertensive disorders in pregnancy. Then we need to arrange urgent delivery, and sometimes we need massive transfusion support to correct coagulopathy and control of bleeding, then the intensive care management. The surgical option for hepatic rupture would be liver packing, hepatic artery ligation, resection, and some cases liver transplantation. Most of the time, this type of patients would be unstable. So liver packing and sometimes hepatic artery ligation would be the best option for the management. Here, the maternal outcome was unfortunately, despite the aggressive management, the maternal deterioration was continued and we couldn't save the mother. And fetal outcome wise, one fetus is demise, other fetus is surviving. And there was a emotional impact, both the family members and also there was a psychological burden on the healthcare team who managed the patient. Here in this case, the learning points I need to highlight are hepatic rupture is a rare but rapidly fatal event. Severe abdominal pain in HELLP syndrome require urgent evaluation. And we need to explain and educate these women why it is important to early seeking medical care in case of preeclampsia and symptoms of preeclampsia to prevent those catastrophic events and improve the maternal and fetal morbidity and mortality both. And early diagnosis may improve survival, although the suspicion is less. MDT involvement is almost always essential in all cases of hypertensive disorders in pregnancies and also the complication with HELLP syndrome. And almost this complication will arise in the high-risk pregnancies. Those need close surveillance. So this is the end of my presentation. The conclusion: spontaneous liver rupture remains one of the most devastating complications of HELLP syndrome. Clinical suspicion is critical for the timely intervention. So increased awareness among healthcare professionals may improve maternal outcome. So clinical suspicion and also the early recognition and early attending to the medical care with presence of these preeclamptic symptoms will save the lives. So these are my references. So this is time to entertain the questions if you have. Thank you.
Hi there, I'm Dr. Shobna Mohandas from Kerala, India. I was the president of Indian Menopause Society a few years back, and that's when I thought I should be having a study for Indian women by Indian women, and I thought it should be on hot flashes. I had 12 other people all over India who were with me in this journey. And exactly what did we study about? It was only a study of vasomotor symptoms, which is feeling of warmth, lasting around 5 minutes, frequency every 10 to 30 minutes, and may cause insomnia, and there can be visible flush. This is what was studied. And the classification was based on grading of the menopause scale rating. No symptom 1, little bit 2, quite a bit 3, and extreme 4. So according to these grades, we decided how much vasomotor symptom she had. Why do we need a study like this? Although we have many things that can be problematic for a menopausal woman, there is a plethora of alternative medicines and even in MHT hormones which are being peddled around saying, oh, you will have hot flash, you'll feel tired, you just take these medicines and you'll be all right. So how much is the need for all these medicines? How much is the actual incidence of hot flashes among a given population? It is given as high as 85%, 50% all over the world. There is really no authentic study where only hot flashes are studied in any study that I could look for among the world literature. They have studied all the menopause symptoms and one person is quoting the other and the other is quoting the other, and there are meta-analysis and things like that. But one original study which is only concentrating on hot flashes incidence, I really couldn't find. And in our study, the study population was 40 to 60 and the all India incidence we found was 37.6 only, compared to the review papers which is giving global rating of 85% and even 50%. This correlates well with the study by Sudha Sharma, who is also one of the authors in our study. She has studied in her area, which is Jammu, which is much, a cold place in India. There's a North American study in climacteric by Dr. E.W. Freeman. There she found the prevalence to be very high, with 46% reporting the symptoms, while in Japan it was supposed to be much lower at around 27%. So it's higher in the American population and lower in Japan, which they attribute to the use of soya in their diet. Now, the global prevalence of hot flashes by a British medical journal, Public Health, in 2024, a systematic review publishes it as 52.6. So in India, it is much lower. And here again, there is a regional variation. In the south where I come from, Kerala, it's only 22%. And in my practice also, if I ask half my patients, I really don't find hot flashes in most of them. It is quite low. Whereas it is highest in central because it came from a place called Raipur. And west also, it was taken from Jaipur, which is a hotter place. North was Jammu, it's a cold place. So there is a place for regional variation. The central giving 65% coming from Raipur is the center of India. Another study from Raipur is from Gaikwad et al. That is also giving a high incidence of 83%. So what we come to know from all this is that regional variations and the climate of the country, all this can affect the how women perceive the incidence of hot flashes. If it is in a colder place, they won't feel the change at menopause that much. Another thing is whether fat tissue really increases the incidence of hot flashes. There are many studies which say there is a prevention of heat dissipation, and the studies have shown an increased incidence in obese women. While there are other studies which show a decreased incidence in obese women because they say the fat converts androgens to estrogens, and you have more estrogen, so it will remove all the hot flashes. After all, it's lack of estrogen which causes hot flashes. So if you have more estrogens due to the conversion of the P450 enzyme in the fat, then you will have less hot flashes. But in this particular study of ours, we found that there is no difference. You can find that the underweight is only 3 in the sample and 2.7 in hot flashes. Normal weight is 47 in sample size and 46 in hot flashes. Overweight percentage is 34 in sample size and 35.2 in the hot flash group. Obese, 15 to 15.6. So what? It's almost the same percent in both the groups, sample and hot flashes. That means the weight has not influenced hot flashes in the study. So that means one group of studies saying more in fat and another group saying less in hot. Maybe it has nothing to do with the fat. It is probably the demographic differences in the studies or the regional differences. Like I said, Raipur is showing more, Jammu is showing less, things like that might have affected it, not actually the fat. Now, even in this incidence, the mild hot flashes is there in 24.7, moderate is 10.6, and the severe incidence where we really push the MHT is only 2.23%. Out of 100, you will get only 2 persons who will really badly need MHT. And with some pushing from you, it will be needed in 12%. And most of the incidents out of the 37 point, the 24%, the most, which is a chunk of the 37, they will just require emphasis on lifestyle modification. And there should be an emphasis more on the morbidities in the older women beyond hot flashes. Like in the studies that we see all over the world, they have studied the incidence of problems in older women, and hot flashes or vasomotor symptoms is part of the study. And they found sleep disturbances and joint pains to be more among older women. Not hot flash as the main thing that they complain about. It may be there. But yes, it is there in 12%, 2% severe, and 10% moderate. So you cannot forget MHT, and you cannot scare people saying MHT will cause cancer and things like that. It is definitely needed and to be pushed. And another thing is hysterectomy increases the incidence of hot flashes and even severe hot flashes with or without removal of ovaries. This is what is there. See, there were 66 women in this 116 total hysterectomized women who had hot flashes. That is a high incidence. It's much more than 37.5. That is 56.8 as against overall 37.5. So if you have your uterus knocked out, your incidence in India will reach the global statistics of 856. Otherwise, it's only 37.5. And out of that, the incidence of severe hot flash is also higher in the hysterectomized women, where among in 37.5, only 22 were mild in India. In the hysterectomized women, the higher incidence is severe hot flashes, not mild hot flashes. That is 23.27% as against only 2.23% in the total study. So if you knock off the uterus, definitely there will be hot flashes. So when the patient comes and tells, don't remove my uterus, I will start feeling hot. My relatives came and said, I will start feeling hot. You will say, no, I won't remove your ovaries, so you won't feel happy. You will not feel hot. You have to rethink that sentence that you're going to tell your patient, because I did find that 10 had their ovaries preserved even with hot flashes, and 30 had their ovaries removed. So out of the 66, 10 had their ovaries preserved means what? Even if the ovaries are preserved, they can get hot flashes. So after all, your patients statement that don't remove my ovaries because I'll start feeling hot may be true, but there is no data for the remaining because there is a balancing act. There is a need to get more data for statistical significance. If you try to get more data, you won't get uniform data in a vast country like India or even a vast place like the world. How are you going to get uniform data? Who is going to collect the data? The women have to be not menopausal women. They have to be just people coming to you with, itching or burning or DUB or some other gynec complaint, and you are asking all these questions. So there is a crux, collection of data somehow cannot be totally uniform. Therefore, you can't really find out whether the ovaries were removed in a few cases. All these things happen in a study. So the fallout of the study is that incidence of hysterectomy is only 7.84% in India as compared to 17 to 26% in developed nations. I think all our folksy presidents who have been pushing the Save the Uterus campaign have succeeded, and that's why we have the small incidence. Yes, the incidence in menstruating women is quite a bit, 30% compared to 41% in menopausal and postmenopausal. So you have to treat these patients also. There are night sweats which accompanies mostly or difficulty in sleep. That is also high. Let's just take them one by one. 63% had night difficulty in sleep in the women who had hot flashes. So people come and tell you, I have sleep disturbance. You have to find out if she's got hot flash and treat that as well. That will be giving a better service to the patient than just giving sleeping pills. Abdominal discomfort. Which woman doesn't come with abdominal discomfort? We have to do a scan to see if there is an ovarian cyst. That's the first thing we do. And the abdomen increases in size as you grow older, whether you're a woman or a man. And so you take this as a common complaint, But there is a higher incidence of hot flashes in these women. The whole study group, there is only 32% abdominal discomfort, whereas women with hot flashes, the abdominal discomfort was definitely higher. So when a woman comes with abdominal discomfort next time to you, you have to take a pointed history and ask her whether she's got hot flashes, because that may help in the treatment plan. Yes, there is a moot question that in this study group, when they asked all the questions, there were a few people who had abdominal discomfort without ultrasound findings or anything, but who did not have hot flashes. Now, can this be taken as part of the vasomotor symptom? That I think the pundits will have to sit around it and decide. Chest discomfort. We all go and get an ECG when anybody gets a chest discomfort. First, they take some gas pills. But definitely, in addition to ruling out that ECG thing and ischemic heart disease, there should be a habit of asking pointed questions to find out if they also have VMS. And if so, treating that VMS with MHT will help in curing her. Because another thing is, another fallout is MHT is also cardioprotective. You can't give MHT only for cardioprotection. But if she's got vasomotor symptom, you are allowed to give MHT. That is the guidelines they say that. And giving MHT can also decrease the chest discomfort she can have. So it can be beneficial for these patients. So in this study, 51 patients with chest discomfort had no hot flashes. Again, like that abdominal thing. So the pundits have to decide whether this can be taken as a part of vasomotor symptom and so on, or whether only having hot flashes can be taken as one. In this study, religion definitely had a role to play. The Christian and Muslim population had a higher incidence compared to the Hindu population, because probably the use of red meat is little higher in these populations. This is the only thing that I can think of as a difference. Of course, many other factors will have to be looked at if you have a proper study on it. But this is an incidental finding that I find that the population is with hot flashes is definitely higher in the Christian and Muslim population. Marital status. Interestingly, divorced or separated people had a higher incidence. Unmarried women also had a higher incidence. So the married women and even widows. So these people had a lesser incidence. So whether you fight with your husband or they are a good companion or not, at least having a husband or having had a proper relation with them, it decreased the incidence of hot flashes. To that extent, it's good to have a husband. Now, employment. In this study, employment did not have a difference. There were global studies where I found that it is higher in countries where there is no employment and things like that. But in this particular study, we did not find that much of a difference in the employment status and not. Yes. So the incidence of hot flashes is 37.5% in India. And here in this study, we have concentrated only on hot flashes. We have not taken, what are your complaints as a woman in this age group. That is not the way the study went on. This is a pointed study asking, do you have hot flashes? And it's only for that. So in that study, the incidence is 37.5. The comparative studies which I had to do in this, when I was writing down the discussion part, most of the studies have been studying everything, and part of it was hot flashes. So there will be a bias in comparing the studies, and one study will copy the other study, and then that will copy the other study, and so this high incidence of quoted incidence of hot flashes of 85%. When you open the internet, they will say 85% have hot flashes. And then you think everybody needs MHT, which is, I think, not really true. We need more studies all over the world where only hot flashes are pointedly searched for, so we can have an answer to how many people really need and what is the market potential of developing drugs which patients are not scared of. MHT is definitely safe, but still people are scared because they think there will be a dependence on it or there will be side effects. So where do we stand? We need studies on hot flashes only and not just copying one study, which is copying the other study. In this study, it was not correlated with body mass index. Again, we need more studies where hot flashes are concentrated upon. There is a lower incidence in Hindus, probably because of the higher meat intake or not, or whether it is a spiritual angle or whatever, that is beyond the discussion in this particular time. And good news, incidence of hysterectomy in India is only 7.2%. And another thing is, when you meet your patients and they ask you whether it's worth removing the uterus because she will get hot flashes, you have to think twice before saying, no, 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 I'm only removing your tubes, I'm not removing your ovaries, so you will not get hot flashes. Personally, in my practice also, I find that my hysterectomized patients, even though I don't remove the ovaries, however old the woman is, I do remove only the tubes. I do find that they do come back after around 5-6 years and they say, Madam, I have hot flashes. So it's not just the women where you remove the ovaries that you have to warn about hot flashes. You have to tell them that there is a higher incidence, but not everybody gets it. And you cannot deny a myomectomy for a woman in a perimenopause, because in this study also we find that there is an increased incidence of hot flashes in hysterectomized women. We all think that myomectomy is not worth it because anyway the uterus has done its work, so why remove the uterus? Why remove only the fibroid with so much of tension? And anyway, you open the abdomen or you put in a laparoscope, why don't you remove everything after all? A potentially disease-forming organ is there lying inside. No, the study says that the incidence of hot flashes is higher. You would be doing good to the patient if you leave the uterus alone. So thank you so much for this opportunity given. And somewhere I had to present this paper, and this was a very good attempt. Thank you so much.
Hi, good morning. I'm Dr. Sakshi Chopra. Can I present my presentation now?
Yes, doctor, you can present.
Okay. So this is a study which was conducted in the one of my IVF center which I have worked last year. This study is for I have done in 200 women for over 2 years. And in this study, the main aim was that on the day of the trigger, we used to check the serum estradiol levels, and we compared with the number of mature follicles the oocyte receives and the mature oocytes. We have compared the correlation between them and followed it till the clinical pregnancy rate, that is around the 6 weeks of pregnancy. So generally in IVF, the retrieval of sufficient number of mature oocytes are the critical for successful fertilization and embryo development. And one of the key biochemical markers we generally do for the in control ovarian stimulation is the serum estradiol levels. So in natural ovulatory cycle, when there is one follicle growing, the serum estradiol levels are generally around 200 to 400 picogram per ml. But in control ovarian stimulation, the levels may be very high because there are a lot number of mature follicles growing. So the levels are generally more than 10 times. So the relationship between the level of estradiol and the number of the mature oocytes retrieved is very complex. And the relationship between the estradiol and the pregnancy outcomes remain also complex, as both if there is insufficient levels and the excessive estradiol levels will have impact on the pregnancy rates, and they can be suboptimal. So this is a retrospective observational study which is conducted in the Department of Assisted Reproductive Medicine at Ridge IVF Center in Delhi, India, in which 200 women were taken for 2 years, around 2023 to 24. And the age group was 23 to 40 years, undergoing IVF Efficacy treatment. Donor oocytes were excluded in this study. The methodology used is the control ovarian stimulation was carried out using either GnRH antagonist or long GnRH agonist protocol, depending upon patient's characteristics. Serum E2 levels were estimated by the chemiluminescence assay on the morning of the day of the ovulation trigger. The trigger we used to give either injection HCG or dual trigger, which is injection leupride and HCG, when the two leading follicles were more than equal to 18 millimeter. The study, the main primary outcome the study assessed was the correlation of the serum estradiol levels on the day of the trigger to the number of the mature follicles. The mature follicle size which I have taken is more than equal to 14 millimeter. And the serum estradiol levels were compared with the numbers of oocytes received, the number of mature oocytes. The serum estradiol levels were also correlated with the serum AMH levels. The secondary outcomes were measured as correlation of estradiol per oocyte and estradiol per mature oocyte on the day of the trigger. So in my study, the AMH levels were in 4 parts. Less than 1.5 were low variant reserve, 1.5 to 3.5 were the normal reserve, and more than 3.5 were high reserve, which were PCO. The serum estradiol levels were also divided into 4 groups. Group 1 was Group 1 was around less than 1,000, then group 2 was 1,000 to 2,000. Group 3 was 2,000 to 4,000. And group 4 was more than 4,000 picogram per ml. So in my study, which the results came out was as the serum E2 level were higher on the day of the trigger, the number of oocytes received, the number of mature follicles, and the number of mature oocytes were higher. So this helps in me detecting the early detection of the ovarian hyperstimulation syndrome, which was very common in PCO. Then it also helped me in correlating in counseling the patients of especially of the poor ovarian reserve, as the E2 levels in them were low, so we were expecting less number of mature oocytes. Then in my study we found out that as the AMH levels were high, in these patients the serum E2 levels we were expecting to be high, and this was actually the observation which I found out, that on the day of the trigger, especially in the PCO patient, the E2 levels were consistently high. So timely measures were taken to avoid the ovarian hyperstimulation syndrome. Second thing, in terms of the pregnancy rate, we have found out that in patients in the group in which there were higher E2 levels, they have a comparatively better pregnancy rate as compared to the low E2 levels. But the p-value was not very significant, so it was not very statistically significant difference we have found out. So in the present study, what I demonstrated was that the serum E2 on the day of the trigger not only reflect the follicular quantity, but it also reflect the functional competency of the granulosa cell when interrupted alongside the established markers of ovarian reserve and ovarian sensitivity. But serum E2 levels did not predict the clinical pregnancy rate, highlighting that there should be a need for a more composite physiology-based approach. When parameters such as AMH, AFC, FOT, and FOI used together, along with E2 levels on the trigger day, these markers provide a more accurate understanding of the ovarian performance than any individual parameter alone. So I conclude that future studies can further refine this framework and explore its role in predicting the embryo development and cumulative live birth rates. So one of the limitations of my study was it was a retrospective study, and the effect of different protocols on estradiol level was not taken separately. And the study did not conclude the effect of estradiol levels on the quality of the embryos. That's it.
My colleagues, good afternoon. Today I would like to present our study entitled Hormone-dependent diseases of the pelvic organs in the woman over 35 years of age. This retrospective study based on clinical data from Osh Regional Clinical Hospital for the period from 2011 to 2015. The authors it is Aorta, Subanova N.A., Askerov A, Erspive, Jumaeva, and Erspive A.I. It is one of the hormone-dependent pelvic diseases is significant medical slides. Dear colleagues, where slides my? Next slide. Next slide. Next slide. Hormone-dependent pelvic diseases are significant medical and social problem. Women over 35. The incidence is increasing is accompanied by severe complication. It is uterine bleeding and hemorrhagic shock. First off, I would like briefly explain the relevance of this topic. Hormone-dependent diseases of pelvic organs are one of most important problems in modern gynecology, especially among women over 35 of age. This age period is clinically significant because of associated with reproductive aging, endocrine changes, and perimenopausal transition and increasing frequency of gynecological pathology. The most common hormone-dependent diseases include uterine fibroids, endometrial hyperplasia, endometriosis, polycystic ovary syndrome, endometrial polyps, and abnormal uterine bleeding. These conditions may significantly reduce the quality of life women. They may cause chronic pelvic pain, infertility, menstrual disorders, anemia, repeat hospitalization, and severe causes. Life-threatening complications such as hemorrhagic shock. Endometriosis affect approximately 15% of women reproductive age. It is often associated with chronic pelvic pain, infertility, and the diagnosis is frequently delayed. Uterine fibroids are also very common, especially in women between 35 and 15 years of age. Their frequency increasing during reproductive age and menopausal years. Endometrial hyperplasia is another important condition because it is associated with hormonal imbalance. Risk factors such of age of over 35 years, polycystic ovary syndrome, nullipolarity, and perimenopause. Abnormal uterine bleeding is one of most frequent clinical manifestations of these diseases. It is widespread among women of reproductive age, but not every woman seek medical help in time. Therefore, of the structure frequency hormone-dependent pelvic diseases in over 35 highly relevant for clinical practice, especially for improving diagnosis, prevention, and treatment strategies. The IMO study was of analysis the structure of frequency hormone-dependent diseases, pelvic organs in women 25 years of age, according date from OSH period 2011 to 15. Так, next slide. Next slide. Нет, stop. These, now I will move to its materials and methods. This was retrospective study. This the study was conducted on the basic gynecology department or regional clinical hospital. The study won, the 2011-2015. A total of 199 medical case histories were analyzed. The inclusion criteria were women over 35 years hospitalization gynecological department during selective period of 2011-2015. The methods examination including clinical examination, ultrasound examination of the pelvic organ, histological analysis, and analysis of medical records. The column that were processed using Microsoft Excel, mainly of calculation absolute numbers of percentage. The main parameters studied structures. The main parameters studied in the structures of prevalence of hormone-dependent gynecological disease complication, concomitant diseases of volume of type of surgical intervention, and the intervention in the relationship with the place of residence of rural and or urban. This study was approved of the Medical Ethics Committee Faculty Medical Science of State University in the February 2025. Next slide. Now let's look result of our study. The total of the 199 female patients were included of analysis. Most of us had rural residents, especially 70.5% of women lived in rural areas, while of 20.5% lived in the city. Regarding the distribution of largest of group consists of women aged of 35 and 40 years, who is accounted for that 50.5% all of patients. Women age 41 and 45 age of responding to 22%. Women aged 46 on the 50 age accounted for 11.5%, and the women 50 years accounted for 12.5%. According to the marital status, here 67.5% the patients were married. On average, approximately 40 hospitalizations per year were recorded during 5-year study period. Next slide. The analysis, it is the venostructural gynecological diseases common the pathological uterine fibroids. When after the diagnosis, patients with correspondence to the 20.5%. The second most frequent condition was endometrial hyperplasia, diagnosed 50% or 25% on cases. The third most of frequent pathology was ovarian cyst with torsion, found in the 35 patients, corresponding 7 to 17.5%. Endometrial polyps were diagnosed in 21 patients or 10.5%. Endometriosis was found in the 13 patients, which corresponded to 6.5%. Thus, the is leading disease of structural hormone-dependent pelvic pathology, worldly uterine fibrosis, endometrial hyperplasia, together with condition condom was half the major gynecologic diagnosis in women over 35 years old. Next slide. Next slide. Sure, stop. Now would like presenting diet complication. This one of the most complication abnormal uterine bleeding was observed in 20% of patients or in 50 cases. Heavy menstrual bleeding was registered in 8.5% of the patient. Hemorrhagic shock was rare and occurred in 1% of cases, but it should be emphasized that this in severe potential life-threatening condition. Now the analysis of concomitant disease of Chauvet and common associated condition was anemia, which was found in 59.5% of patients. This is important finding because anemia often related of chronic of heavy uterine bleeding. Genital tract infection were observed in 49.5% of patients. Cystitis was found in 35.5%. And obesity was observed in 35.2% of patients. These findings show that it is hormone-dependent gynecologic disease often occur together with implementary, metabolic, and general somatic condition. Now I will, it is described in the surgical intervention. The most one of common procedure vacuum aspiration, which was performed 20% of cases. Hysterectomy was performed in 18.5% of cases. Cystectomy was performed in 70.5% and myomectomy in 9% of patients. Removal of submucous node was performed in 1.5% cases, while cold-for-away was in very rare. The data demonstrates that surgical treatment remains an important part of management in the women hormone-dependent pelvic diseases. However, during of study period, there was the tendency toward a reduction in radical operation, increasing and a minimal invasive of the organ preserving intervention. Next slide. Now that I moved it is about discussion. First is height proportional roles, 7.5% is important demographic finding. This may relate population structure of the OSH region, higher birth rates of rural areas, limited access to early outpatient gynecological care, and related referral to the specialized medical service. Second, of predominance of the 35-40 years shows the hormone-dependent gynecological diseases may occur related to the early of late reproductive age. This age group requires special attention because many women may still have reproductive plans, while at the same time they already have increasing risk endocrine and structural gynecological disorders. Third, it is done. It is third, it is dominance that it is uterine fibrosis, endometrial hyperplasia, confers hormone dependent cross nature pelvic pathology in this age of age group. These diseases are closely associated with estrogen-dependent mechanism of become especially prevalent during of the late reproductive menopausal periods. Court of abnormal uterine bleeding was the one key clinical manifestation of the complication. It was identified in the gradder of the patient. These findings are clinically important because abnormal uterine bleeding may lead to anemia, repeat constipation, reduced quality of life, and organ surgical treatment. Fifth of the high frequency of anemia, genital tract infection, cystitis, obesity indicates the patient of hormone-dependent diseases require comprehensive clinical approach. It is not enough to treat only gynecologic diagnosis. It is also necessary to correct anemia, treat infection, assess metabolic risk factors, and provide follow-up care. Finally, the surgical diet shows a positive tendency toward organ-preserving treatment. This is very important modern in gynecology. Radical surgery such as hysterectomy should be used only when clinically justified. Wherever possible, minimally invasive and conservative approach should be preferred, especially in women who wish preserve the reproductive hormonal function. And the next slide. Conclusion. I would like to summarize the main conclusion of our study. First, hormone-dependent gynecologic diseases widespread among women 35 years in region OSH. Second, of leading nosological forms, uterine fibroids, which account 26.5%, endometrial hyperthyroid 25%, ovarian distortion 70.5%. Third, abnormal uterine bleeding occupies a significant place of structural complication was observed 25% of patients. Hemorrhagic shock it is only rare, only 1%. The fourth of most common disease of anemia, it is the 59.5%, and the genital tract infection 49.5% of patients. Fifth of the result indicate the trend toward reducing radical surgical intervention, increasing minimal invasion of organ preserving procedure. In conclusion, over 35 years should be considered of priority group of early diagnostic, prevention examination, timely treatment, and a dynamic follow-up. Special attention should be given to abnormal uterine bleeding, anemia, endometrial pathology, and uterine fibroids. The practical significance of study this may be help improve gynecological care, optimize the diagnostic algorithms, and the support of development organ preserving treatments strategies for women in the OSH region. Thank you for attention. If you have answer, you have that. And I talked about it is the DIA organization committee. Thank you for opportunity to participate for interesting webinar from research, practice, innovation in the women health. I appreciate the sense of share my presentation, exchange the professional experience with my college. It is your colleague Subanova Guljamalashna. Thank you very much.
Good time. Distinguished chairpersons, respected colleagues, and honored participants. My name is Faride Yazdan Panoh, and it is a great honor for me to participate in this prestigious international conference. I hold a Bachelor of Science degree in midwifery, a Master of Science degree in embryology, and a Master of Science degree in medical education. I am affiliated with Laristan University of Medical Sciences, Iran, and I am also a member of the Medical Council of the Islamic Republic of Iran. My academic and professional activities have been primarily focused on reproductive health, women's health, embryology, and medical education. In this presentation, I am pleased to share our work and findings with esteemed researchers and professionals from around the world. I sincerely appreciate the opportunity to contribute to this scientific gathering. The title of my speech is Treatment of Infertility Due to Premature Menopause Using the Tajik Method, a Case Report. Introduction and Aim. Age criteria and hormonal factors have long been used as one of the most important factors in determining successful pregnancy. Decreased anti-Mullerian hormone, increased FSH hormone, along with menstrual disorders, has always been associated with the suggestion of IVF and donor eggs. The aim of this report is to evaluate the effectiveness of lifestyle modification using the Tajik method on the treatment of infertility due to premature menopause. Case presentation. A 39-year-old woman living in Iran who got married at the age of 36 referred to an infertility treatment center for treatment after 2 years of trying to conceive and failing. In the family history, the patient's two older sisters both had severe menstrual disorders and infertility for more than 10 years. Hormonal tests and checkups and ultrasound were prescribed for this patient. Laboratory findings showed AMH equal 0.221 and FSH equal 22 and hypothyroidism. Hormonal treatment was started for this patient. After 3 months of no response to hormonal treatment, the patient was advised to use donor eggs. Since the patient's wife opposed donor eggs, the patient referred to me for lifestyle modification. The patient was treated with Tajik lifestyle modification, which includes stress reduction techniques, appropriate exercise, sleep pattern modification, and a proper diet. The patient's acceptance of the training was very good, and she cooperated very well during the treatment. The patient became pregnant after 6 months of complete Tajik lifestyle modification, and now her baby has been born. Conclusion. Given the increasing age of marriage and the increasing rate of infertility, and considering that lifestyle modification is a very low cost and low risk method compared to IVF or pharmaceutical methods, more attention to encouraging the treatment of infertility due to premature menopause with Tajik lifestyle modification seems necessary. Thank you very much for your kind attention.
Bismillahirrahmanirrahim. Dear distinguished chairs, esteemed judges, and all colleagues joining us both in person and virtually. I'm Dr. Firuze Ahmadi, an Associate Professor of Radiology at Ruyan Institute for Reproductive Biomedicine from Tehran, Iran. I have no conflicts of interest to declare regarding the content of this lecture. Thank you, and let us begin. Here we talk about hysterosalpingography in the post-operative uterus evaluation, imaging findings, pitfalls, and limitations. The uterus is a hollow pear-shaped organ with a complex anatomical structure whose function depends critically on the preservation of its structure. Various gynecological diseases can damage this anatomy. Surgery is the preferred treatment for many acquired and congenital gynecological conditions. Gynecologic procedures aim to restore normal uterine anatomy and function, thereby improving symptoms, fertility outcomes, or both. Surgical interventions, from minimally invasive techniques to more extensive operations, can inadvertently harm the uterine structure. Although often essential and beneficial, each surgical procedure carries a spectrum of potential complications. Therefore, precise assessment of post-operative changes is essential for reliable diagnosis and optimal patient management. Imaging is integral to uterine assessment. Modalities including transvaginal ultrasound, saline-infused sonohysterography, magnetic resonance imaging, and hysterossalpingography provide complementary information on uterine morphology and pathology. Despite the advent of advanced cross-sectional techniques, HSG continues to be routinely employed in infertility evaluation and is valuable for evaluating abnormalities of the uterine cavity and fallopian tubes. Here we focus on the HSG method. Any surgical procedures involving the cervix, uterus, or fallopian tubes may produce characteristic findings on post-operative HSG. These can range from subtle or readily apparent. Here we describe the most important findings resulting from corrective surgery or congenital anomalies and from procedures performed to treat acquired diseases. A unification procedure is not necessary in most women with a septate or bicornate uterus, but if performed, a postoperative HSG is necessary. These procedures result in characteristic findings at hysterossalpingography. Historically, septum surgery involved complete excision, which often resulted in a reduced uterine cavity. Hysteroscopic septoplasty is not the preferred technique. In patients with a long septum, residual septal tissue may remain after hysteroscopy, and the fundal contour can return an arcuate appearance. Post-operative complications include intrauterine adhesions and obstruction with the accumulation of secretions. The first image was taken after septum resection using outdated surgical methods. HSG shows a narrow fundus with a small wedge-like septum, an arcuate pattern, a smaller uterine cavity, and two small lateral dog ears. The second image shows adhesions following septum resection. The third image shows a residual septum in the cervical and fundal regions following an attempt complete septum resection. The fourth image shows a resection of the left half of the uterine following complete septum surgery. The common surgical complications diagnosable on hysterossalpingography include intrauterine adhesions, cavity distortion, uterine pelvic adhesions, tubal occlusion, uterine niche, and fistula. Intrauterine adhesions may develop after any surgical procedure that mechanically damage the endometrium, including dilation and curettage, hysteroscopic resection, myomectomy, caesarean section, and endometrial ablation. IUS consists of fibrous bands that connect opposing uterine walls and are classified as mild, moderate, or severe. They may partially They may partially or completely obliterate the uterine cavity. IUIs are a leading cause of secondary infertility. On histosephanography, IUIs typically appear as linear or band-like filling defects or as irregularities of the uterine content. The two upper slides show mild adhesions involving less than 1/4 of the uterine cavity, and the two lower slides demonstrate moderate adhesions involving between 1/4 and half of the uterine cavity. The two upper slides show severe adhesions involving more than half of the uterine cavity. The two lower slides show complete adhesions. The cavity is not opacified at all. A variety of gynecologic interventions, including abdominal or hysteroscopic myomectomy, septoplasty, repeated dilation and curettage, endometrial ablation, adenomyomectomy, and caesarean delivery, can alter the normal triangular configuration and volume of the uterine cavity. Also, myomectomy and septoplasty are performed to restore normal anatomy. Post-operative distortion may result from focal wall retraction, over-resection, incomplete septum removal, or intercavitary fibrosis. On histosephanography, these changes appear as deviations from the expected symmetric triangular cavity, including focal or global cavity narrowing, angular or concave contour irregularities, and asymmetric coronal outlines. This image shows uterine cavity distortion following myomectomy. The second image shows severe distortion and adhesions on the right side of the uterine cavity following curettage. The most common of all post-operative findings is a scar left by a lower segment caesarean section, uterine niche. This is ordinarily a judged wedge-like, sharp contour defect in the area of the lower segment and is characteristic of this operative procedure during an incident pregnancy. Its muscle forms months or years later and can cause various issues, including abnormal bleeding or embryo implantation failure or early pregnancy loss, potentially secondary infertility or complications during future pregnancies, such as placenta accreta. Unilateral caesarean section scar in the isthmus region is seen here, and unilateral and bilateral caesarean section resulting from two different caesarean section surgeries are shown in this image. Bilateral diverticulum of the caesarean section scar, you can see in this picture, and large secular caesarean section scar in the fourth image is shown. Pelvic adhesion are an acquired pathological condition in which fibrous bands form between pelvic organs and ovaries or fallopian tubes, uterus, bladder, or bowel months to years after open or laparoscopic surgery. Pelvic adhesions are an important cause of secondary infertility, particularly following open myomectomy or multiple caesarean deliveries. On HSG, you can shape sharp cutoff of contrast at the tubal ostium without interluminal filling or peritoneal spill. For mid-tubal segment occlusion, a contrast fills the proximal tube but stops within the mid portion, producing an abrupt termination in the tube's course. And for distal obstruction and primary dilation or hydrosalpinx with absent peritoneal spill, we have, and the tube appears markedly dilated and serpiginous. Peritoneal adhesions is shown as located or restricted contrast dispersion, fixed or corkscrew appearance of the tube, limited tube mobility on serial images, or hinging angulation as seen as well. Pelvic adhesions following myomectomy is shown in the first picture, the first image. Both tubes are fixed and located above the fundus of the uterus without peristalsis. The second image shows bilateral proximal tubal obstruction due to adhesions following myomectomy. The second image shows complete obstruction of the left tube and the mid portion of the right tube due to adhesions following cesarean section. Unilateral hydrosalpinx of the right tube following myomectomy is seen in the fourth image. And the fifth image shows bilateral hydrosalpinx following cesarean section. Fistula. Post-surgical fistulas are uncommon but important complications of gynecological conditions. A fistula is an abnormal tunnel-like connection between the reproductive tract and another pelvic organ. HSG fistulas appear as abnormal passage of contrast media from the reproductive tract into adjacent organs or spaces. Common causes include cesarean section, hysterectomy, myomectomy, dilation and curettage, uterine perforation, difficult labor, pelvic infection, radiation therapy, and other pelvic surgeries. The most frequent types include vesicouterine, vesicovaginal, uteroperitoneal, and intrauterine fistulas. In this picture, the first picture, you see bilateral fistula following the cesarean section square to the uterine bladder. Unilateral fistulas tract from the cervix and isthmus to the uterine bladder is seen in the second picture, that's following a cesarean section score. And the third picture shows pudendal fistula following myomectomy. Thank you.
Good morning from London and good afternoon in Malaysia. Actually, I am Dr. Mina Tajvidi. I am presenting on behalf of the Flora Tajiki. Unfortunately, Flora Tajiki, due to the current situation in Iran and because of the internet outrage, she couldn't join us today, so I am just going to present on behalf of the Flora. I am not gynecologist, I am not midwifery, but however, I am the senior lecturer or associate professor in the emerging technologies in the healthcare. So today, I would like to present on behalf of the Flora based on effectiveness of the Flora lifestyle modification and improving sperm morphology and achieving successful pregnancy. But before moving to the presentation, I would like to have like a short bio of the Flora. Who is she? What is the Flora's lifestyle modification? So as you see in the screen, so the Flora is graduated 1992 and is the midwifery specialist, and also she's the specialist in infertility treatment because it's also the Flora the suffering from the infertility long time ago, and based on these treatment of the Flora's the modification, he treatment herself. But however, before just going into more details about the Flora, I just want to have like the brief things. What is the things? So pregnancy and motherhood are dreams for many women after marriage and since childhood. So we have imagined being mothers, we care for our dolls with love, and potentially they were our babies. But today infertility has become very common, and it is also one of the most expensive treatment in the world, and it's bring stress to many families. So Flora, as she's the midwife and she's once infertile herself for 2 years, she placed newborns into their mother's arms, silently wishing that one day she could feel the same joy. She became pregnant 7 times, but each time ended in miscarriages. So her world turned dark and he falls into depression after all miscarriaging she had. But everything changed when she focused on improving her lifestyle. So through this journey, she eventually had 2 healthy pregnancies and births. This experience changed her path. She began working with more and more women facing infertility. And until 7 years ago, she believed, like many others, that anti-Mullerian hormone showed the true ovarian reserve and could not be increased. But as many women with low AMH came to her, she supported them closely, staying in daily online contact during their treatment, and slowly but surely results started to appear. And the result that imaging lab and ultrasound specialists, given the medical histories, they were shocked. How was this possible? So she began teaching her approach to flu midwives and some doctors, and today more than 2,000 midwives are using her method, and together they are celebrated over 5,000 success pregnancies. So many of her patients had already tried IUI or IVF. Some had been told they needed donor eggs or another IVF attempt and even the donor sperms, but still they trusted them and many found success. So the Floras and team supported clients from all over the world, countries like US, Canada, UK, Ireland, Australia, Japan, Germany, Italy, and more and more. And some of their clients were medical professors themselves, gynecologists even, and cardiologists, physiologists, and oncologists and dentists. And they saw the result with their own eyes, put their trust in the Flora's method, and experience the joy of pregnancy. The Flora's modifications or the life modifications. As like the Flora explains, she noticed that most of the women who came to her with premature menopause were under high level of stress. Once they made lifestyle changes, their symptoms improved. That's why she began calling premature menopause ovarian depression. So as she helped more women, specialists in complementary medicine began asking her to teach them her method. So far, he has trained over 1,000 midwives and doctors, and many of whom have seen great success with their own patients. So using this approach, women have achieved natural pregnancies up to ages of 48 without any hormone modification. Even women age 50 have had successful IVF using their own eggs. So, how we can start this modification journey? So, as like the Flora just expressed even in her book, it just mentioned that 7 years ago, a woman called her in tears. She called devastated. An infertility specialist had told her she needed donor eggs. Her AMH was very low and her FHS was very high. At that time, she believed AMH was the only true measure of ovarian reserve, so she told her she couldn't help. But she was an immigrant and couldn't afford even donor eggs expenses. Back then, Flora was only treating patients with polycystic ovaries. She thought premature menopause had no solution. Still, she wanted to comfort her, so she taught her a few lifestyle changes. A few months later, she got pregnant naturally and gave birth to a healthy daughter. 4 years later, she had a son, both for convenience with her own eggs. This experience opens Flora's eyes. Now, during treatment, they always check hormone levels. Sometimes AMH is low, but FSH and ovary size are normal. This is not worrisome and often improve with 2 months with lifestyle changes. Or if the AMH is low, if the FSH is high, but ovary size is normal, even at 45, it is treatable. And even when ovaries appear atrophied, again, they see success with cooperation and time. And they notice that health lifestyle changes not only improve fertility, but also help other issues, diabetes, fatty liver, high blood pressure, autoimmune conditions, endometriosis, and ovarian cyst. They also improved sperm quality and reduced DNA fragmentation. A healthy lifestyle even reduces pregnancy risk like preeclampsia, miscarriage, and gestation diabetes. What caused premature menopause? They observed that the following trigger in their patients: job stress, loss of loved one, emotional trauma, migration, viral infection, poor lifestyle, and even the COVID vaccine, as reported in the some cases. So, what is the floral lifestyle method? At the start of the treatment, every therapist begins with a sense and heart-to-heart conversation with the patient. Sometimes this first conversation can last up to 3 hours. And then they take detailed medical and emotional history. They discussed all their previous treatments and they ask them what they truly want and what they have most afraid of. And then they also share real stories of the women who have successfully been treated. And finally, they create personalized and plan just for them because every woman in journey is unique. And then their patients became part of their online support group where they share their daily activities and progress. And they feel confident knowing that their therapist is always present, supportive, and available throughout their journey. And every day, their team receive positive pregnancy test result from women who were once told by a top medical or gynecologist that natural pregnancy was impossible for them. And just last month, a woman gave birth after 8 years of amenorrhea, and her ovaries were atrophied, and her FSH level was over 100, and she stayed under her full care and support for a year and a half, and today she holds her baby in her arms. So all those the patients in their study represent just a small glimpse and drop in the ocean of the amazing result they have seen it. So what they are doing in the healthy lifestyle modification, the first, the cut consumption of sugar and any preservatives, dairy foods, processed food, fast food, unhealthy oils, and even leftover food. And they consume very healthy vegetables and suitable meat and limit dairy intake based on each the patient's situation. And they consume food with proper washing and peeling, reduce consumption of fried food, consumptions of fruits and nuts, and consume probiotics. And the important things is sleep. So the sleeping routine is one of the key factors in the Flora's healthy lifestyle modifications. So they have to sleep at least 8 hours per day per night, and the timing hours started from 11 until 8 in the morning. So the other things is very important is that the self-love, self-awareness, effort, patience, and perseverance, believe and trust, lifestyle, proper planning, eliminating excuses, goal setting, facing fears, stress reduction, creativity and artistic work. For example, each of the patient, they have to do some artist things like art, like drawing, like any kind of the art they would like to do it every day to just a piece of their minds about all of the stresses they wanted, and they are sharing those daily lifestyle things through their groups, and their the midwiferys or any person, they are caring them every day. They are checking that what they are eating every day, what they are doing, what, for example, dancing every day. They are doing the yoga, they are doing some exercises, the walking, how they feel happiness during the day. And they sharing these stories, which is really great because they are in community, they are doing together these lifestyle modifications. If they have any questions, the Flora team, they are here, they're answering their questions, and they keep the patient's mind in peace. So here is just only examples that how is there the tense. It's just just only the examples. They have like 5,000 the patients they experience the natural pregnancy. So in the patients with the different ages, as you say, like 38 until 40, 41, and even above, with like AMH is lower than 0.2, and all of them were candidate for the donor, egg donor, and based on these Flora's modifications, they had the natural pregnancy. And even the Flora, they publish all the stories of those patients. They have like natural pregnancy in their books. As you see here is the Smile of the Life from Flora Tajik. It is the full of the stories of the women's. They just naturally pregnant based of their lifestyles of the Flora modifications. So as you see here, so this shows that like the patients with the different timeline, they had, the FSH test, LHS test, TSH test, and, T4 for troids. And based on the lifestyle period, how, for example, their AFSH, as you see in this screen, and the top and the left side is just reduced. Or how it's like LH is from the highest one, they became very normal, or the time they had like their life modifications. So for example, FSH, it was the highest 75.38, but during the 1 year and half, they just bring it to the 20, and even based on LHS, and they improve AMH, as you see in the left sides. So like 0.3, it was like the AMH one, and now they have like 1.1 during the 1 year lifestyle modification. So it can be different. So from some patients, they have like a short term, they can just improve the dose of FSH, LH, and AMH. Or even for some of them, they are longer, depends on that their partners, their husband, how is like the sperm modifications. And also this is one another story is that to show that so how is like even the poor sperm morphology is frequently identified in cases of a male infertility. So the head shape is spatially crucial in and impacts on the sperm ability to pretend the oocyte. So the sperm head also carries the genetic material like DNA and making morphologies analysis vital in fertility assessment. So the test focus not only on head shape, but also examine the midpiece and tail for any structural issues. So given its crucial role in natural conceptions and improving sperm morphology through the lifestyle changes may spread a viable therapeutic pathway. So this study is also the focus on the male partners of the 5 women undergoing infertility treatment due to the premature ovarian insufficiency. So all male participants were over 40 years of age and had reported the low sperm morphology. So the with lifestyle interventions, so as is like including sleep, dietary adjustment, cessations of alcohol or tobacco products, so regular physical activities, stress reduction techniques, body massage, and consumptions of nutrient-rich nuts. So after several months of adherence to these lifestyle changes, so the women convenes naturally and delivered healthy babies. So I am just going to talk about this, the real cases of the ladies. And also she was suffering from low AMH or the low egg reservations, and also on the other hand, the morphologies of her partner, the husband, was very, very low. So I am just going to talk about this patient's language. And she said that I was born in 1986, like 39 and 40 years old, and have been married for 10 years. About 8 years ago, I decided to see a doctor to begin the process of trying to get pregnant. After some checkups, I discovered that my ovarian reserve was lower than 1. And the doctor advised me to wait for another year. A year later, I returned to the doctor and was told that I had a polyp in my uterus. And after further testing and biopsy, we tried again to conceive. It was also the first time my husband was tested, and we found out he has grade 3 varicocele. And we visited the fertility center, and he underwent surgery, and the doctor told us it would take about a year for these conditions to improve. After that, we immigrated to Canada. As soon as I could, I visited a fertility center, and the gynecologist, highly expert in fertility, who has published widely studies at several U.S. universities, including Stanford. He teaches at McGill University in Canada. He prescribed letrozole and asked her to take it for 6 months. After that period, extend the treatment to another 6 months, but eventually her ovarian reserve dropped again, even lower. She needed to proceed with IVF as soon as possible. After the IVF, only 2 embryos were formed, and both of which were transferred, and however, the pregnancy ended in miscarriaging at week 4. Despite following up, she received no explanation. The doctor simply told her to keep repeating IVF until it works, and that she would eventually need to use donor eggs. And also, the doctor also told her that. So she changed her doctor and started seeing another doctor, who's a gynecologist, is an expert who received a gold medal from Harvard University. He told her that he would never donor eggs because her ovaries reserve had dropped again. And however, he suggested trying IVF one more time before turning to donor eggs. And by coinciding, she met a colleague who introduced her to Mrs. Tajiki, and she started changing her lifestyle and practicing yoga, eating healthy, avoiding preservatives, and even baking her own breads. And after a year of this healthier lifestyle, her ovaries reserve, again, see that dropped again. But she had the chance to meet the Flores in person, and she told her that ovarian reserve has no direct correlation with fertility, and she also said that her husband had very low sperm morphology and created a specific diet for him. A year passed with lifestyle changes and acupuncture as well, and her stress level significantly decreased, and for the first time in a long time, she could sleep through the night. And her husband's sperm morphology improved from 4% to 29%, as you see in this slide. And finally, against all odds, she became pregnant naturally. And it is a God's miracle. And she said that I will always be grateful to Flora's lifestyles. How after years of waiting, praying, trying, falling, rising again, and trusting the wisdom God replaced, her miracle arrived. And in 24 October, in early morning, in the 40th week, with a completely healthy boy, a perfect heartbeat, and their little angel was born. So, it was the story of the Flora's lifestyle and how she helped thousands of the women that can experience this miracle with their hands. So this is the books of the Flora, Smile of the Life, which is like the hundreds of the women's real stories with like the all evidence how they had this experience through the Flora's the lifestyle, and they can just be successful within their pregnancy. So, thank you so much for listening. And I know maybe I can't get your questions, but here is the Flora's Tajiki's the emails, and then so you can just reach out. But if you have any questions, and also I can just write down, and just pass it to the Flora, and she can just answer you if you just email or just give the email address to me. So yeah, this is my end of the presentation.
Hello everyone, my name is Dr. Aybüke Tayarar. I am an assistant professor and obstetrician and gynecologist from Turkey. Today I am very pleased to present our study entitled Urethral Ligament Plication with a midline approach for stress urinary incontinence, preliminary experience and outcomes. As we know, stress urinary incontinence, or SUI, is the involuntary leakage of urine during activities that increase abdominal pressure. These activities may include coughing, sneezing, laughing, exercise, or physical effort. SUI is a common condition in women, and it can negatively affect daily life and quality of life. The treatment usually starts with conservative options such as lifestyle changes and pelvic floor muscle training. However, in selected patients, especially when conservative treatment is not sufficient, surgical treatment be recovered. In patients with a positive history and or positive cough stress test, the evaluation can be summarized in 3 steps. First, urethral hypermobility is assessed with the Q-tip test. Second, potential surgical benefit is evaluated with the Marshall-Bonney test. Finally, surgical treatment options are considered either with mesh or without mesh. From an anatomical point of view, continence depends on the coordinated function of the pelvic floor muscles, the vagina, and the supporting ligaments. Therefore, the main aim of surgery is not only to support the urethra, but also to restore the anatomical structures responsible for continence. Although mid-urethral sealing surgery is still an effective treatment for stress urinary incontinence, mesh-related concerns have changed the clinical landscape. Mesh complications, legal issues, and regulatory warnings have increased the interest in alternative surgical options. For this reason, mesh-free and minimal invasive techniques have become more important in selected patients. Urethral ligament plication may have a potential role in this area. It is based on native tissue support and uses sutures instead of mesh or tape. However, I would like to emphasize that this technique is not presented as a replacement for mid-urethral sealing surgery. Our aim was to explore a simplified, less invasive modification for selected patients with SUI. Continence depends on a coordinated anatomical mechanism. The pubourethral ligament, or PUL, plays an important role in supporting the urethra, especially during coughing or physical stress. According to the integral theory described by Petros, the pubourethral ligament and the pubicoccygeus muscle are key structures for urethral closure. When intra-abdominal pressure increases, these structures help stabilize the urethra and maintain continence. If the pubourethral ligament becomes lax or elongated, urethral support may be weakened. As a result, the urethral closure mechanism may fail and stress urinary incontinence may occur. Therefore, repairing or reinforcing the pubourethral ligament may be an anatomical target in selected patients with SUA. In the original urethral ligament plication technique described by Petros and Palma, bilateral paraurethral incisions are used. In that technique, several key attachment points of the pubourethral ligament are repaired bilaterally. These include the mid-urethral component, the retropubic component, the external urethral ligament, and the pubococcygeus muscle related component. In our midline approach, the procedure is simplified. We use only one vertical midline vaginal incision, approximately 2 centimeters below the urethra. Through this single incision, we reach the retropubic branch of the pubiurethral ligament of both sides. Then we pass a non-absorbable polyester suture through these retropubic branches, and they do not at the midline beneath the urethra. So our technique does not require all components of the original ULP procedure. Instead, it focuses only on the retropubic branch of the PUL with the aim of providing a simpler and less invasive modification. The objective of this study was to evaluate the short-term outcomes of urethral ligament application with the midline approach. We considered this technique as a minimally invasive surgical option for selected patients with stress urinary incontinence. Our primary outcome was the post-operative cough stress test. This test was evaluated on postoperative days 7 and day 30. Our secondary outcomes were operative time, length of hospital stay, and postoperative complications. Since this was a preliminary study, our main intention was not to make a definitive conclusion. Instead, we aimed to generate pilot evidence about the feasibility and short-term safety of this simplified technique. We also aim to provide a basis for larger prospective studies in the future. This was a retrospective observational study. We included 30 women, 23 women diagnosed with stress urinary incontinence. The study was conducted at the Department of Obstetrics and Gynecology, Kırşehir University Training and Research Hospital. This study period was between 2023 and 2025. All procedures were performed by a single surgeon. The patients were followed postoperatively on day 7 and day 30. Ethical approval was obtained. Data were collected from hospital records, operative notes, laboratory results, and outpatient follow-up forms. For statistical analysis, we used the SPSS version 29.0. Patient selection was very important in this study. We did not evaluate this technique as a general procedure for all patients with stress urinary incontinence. We include patients with a history of SUA symptoms and a positive cough stress test. The cough stress test was performed with approximately 300 milliliters of bladder filling. We also included patients with urethral hypermobility on the Q-tip test. Another important criterion was continence with retropubic support during the Marshall-Bonney test. All patients had at least 1 month of postoperative follow-up. We excluded patients who had surgery for indications other than SUA. We also excluded patients who underwent concomitant TOT or pelvic organ prolapse repair. Operations performed by different surgeons and patients with incomplete follow-up data were also excluded. In summary, this technique was evaluated in carefully selected patients with demonstrable ligament support responses. This slide summarizes the surgical technique of midline ULP. All procedures were performed under spinal anesthesia in the low lithotomy position. 1 gram of intravenous cefazolin was given for prophylaxis. Foley catheter was placed under sterile conditions. Details in the following slides. This slide shows the first steps of the surgical technique. First, vertical midline vaginal incision is made approximately 2 centimeters below the urethra. This single midline incision is the main difference from the original bilateral paraurethral approach. After the incision, bilateral paraurethral dissection is performed through the same route. The dissection is continued until the retropubic branches of the pubourethral ligaments are palpate on both sides. The aim of this step is to reach the ligament's target without placing any mesh or tape. This slide shows the final application step of the midline ULP technique after identifying the right and left number 2 bubble polyester suture is passed through both branches. Then the suture is tight and the midline beneath the urethra. In this way, the lateral retropubic PUL branches are approximately toward the midline. The aim is to provide ligament support under the urethra without using any mesh or tape. Finally, the vaginal mucosa is closed with a 2O polygalactan suture. This is the key technical point of the procedure. In this slide, I would like to explain how we assess the outcomes of the procedure. Before surgery, all patients underwent a detailed clinical evaluation. This evaluation included medical history of stress test, Q-tip test, Marshall-Boney test, POP-Q examination, and hemoglobin measurement. During surgery, we recorded operative time and perioperative complications. After the operation, patients were followed on post-operative day 7 and day 30. At follow-up visits, both subjective symptoms were evaluated. The cough stress test was performed with a bladder volume of at least 300 milliliters. The patient was placed in the lithotomy position. The labia were separated, and the patient was asked to cough 2 to 3 times. In our study, the cough stress test was used as a separative observational tool together with patients' reported symptoms. This slide shows the baseline and perioperative characteristics of the study population. The average age of the patients was around 57 years. Most of the patients are orated and postmenopausal. Since patients with a primary prolapse indication were excluded, or all patients had only stage 0 or stage 1 prolapse. The median parity was 3. The mean total vaginal length was 9.0 centimeters. The mean perioperative hemoglobin level was 12.8 grams per deciliter. The mean postoperative hemoglobin level was 12.1 grams per deciliter. The mean operative time was 37.4 minutes. The mean hospital stay was 1.26 days. The Foley catheter was removed 24 hours after surgery. This slide summarizes the short-term continence outcomes. On postoperative day 7, 69.6% of the patients had a negative cough stress test. On postoperative day 30, this rate increased to 73.9%. When we evaluated subjective symptoms, 78.3% of the patients reported no SUA symptoms. at day 30. However, 21.7% of the patients still had persistent symptoms. Overall, continence outcomes improved between day 7 and day 30. This may suggest a possible progressive support effect after the procedure. This slide shows the factors. 30 patients with a positive COVID stress test at day 30 were older, had a higher BMI, and had a longer operative time. The mean age was 63.5 years in the failure group, compared with 55.3 years in the successful group. The mean BMI was also higher in the failure group. In addition, operative time was longer in patients with persistent positive cough stress test. These findings suggest that advanced age and obesity may negatively affect short-term surgical outcomes. Longer operative time may also reflect technical difficulty or the early learning curve of the procedure. Although all patients with failure were postmenopausal, menopause was not statistically significant, probably because of the small sample size. This slide summarizes the safety profile of the procedure. We did not observe any major intraoperative complications. There was no acute urinary retention, no hematoma, and no organ injury. The overall early complication rate was 8.7%, which means 2 out of 23 patients. One patient developed infective granulation tissue on postoperative day 27, and it was excised under local anesthesia. Another patient reported severe vulvar pain at 1 month. However, laboratory tests were normal and pain resolved spontaneously. The mean hospital stay was 1.26 days. The catheter was removed 24 hours after surgery. However, some outcomes could not be assessed in the early periods, such as dyspareunia, chronic pelvic pain, and durability beyond 1 month. In this slide, I would like to explain the possible mechanism behind the improvement in continence. The technique is based on ligament support. Bypassing a non-absorbable polyester suture through the retropubic branches of the pubiurethral ligament, we aim to reinforce the ligament support beneath the urethra. In addition to this mechanical support, a biological response may also contribute to the effect. After surgery, neocollagenesis usually begins during the early healing period. Granulation tissue formation and type 3 collagen synthesis are expected, especially between days 3 and 21. After approximately day 21, the remodeling phase begins. During remodeling, type 3 collagen is gradually replaced by stronger type 1 collagen. This process may continue for several months and sometimes up to 1 year. Therefore, the improvement between day 7 and day 30 may reflect not only immediate ligament support, but also a progressive collagen response around the suture. However, this mechanism was not directly proven in our study, and it should be interpreted as a possible explanation. This slide places our results within the existing ULP and non-mesh literature. Petros and Palma reported a very high early success rate with the original bilateral paraurethral ULP technique. Sivaslioğlu from Turkey and colleagues reported an 83% rate at 12 months in their ULP series. Brosovanu and colleagues reported a 70% improvement rate in patients treated with ULP. In our current pilot study, the negative cough stress test rate was 73.9% at post-operative day 30. However, our technique was different. We used a simplified midline approach and repaired only the retropubic branches of the pubourethral ligament. So, these results should be interpreted carefully. The comparison is indirect because the study is different in surgical technique, follow-up duration, surgeon experience, and patient selection. This slide explains why our success rate may be lower than the original ULP technique. First, the scope of the technique is different. The original ULP repairs multiple critical sites related to urethral support. In contrast, our midline approach addresses only the retropubic portion of the pubourethral ligament. This makes the procedure simpler, but it may also limit its effectiveness. Second, the learning curve may have influenced the results. All procedures were performed by a single surgeon, and the surgeon had only recently started using this technique. This may explain the longer operative time compared with some previous reports. Third, patients-related factors may also be important. In our study, patients with failure were older and a higher BMI. This suggests that tissue quality and biomechanical demand may affect the success of ligament-based repair. Therefore, the central measure is feasibility, not definitive equivalence with the original ULP technique. This slide summarizes the strengths and limitations of our study. We also observed an initial safety signal for this mesh-free procedure. However, there are important limitations. The sample size was small with only 23 patients. The follow-up period was short, only 1 month. The study was retrospective and did not include a control group. Also, long-term outcomes such as dyspareunia, chronic pelvic pain, and durability could not be evaluated. Finally, the learning curve may have influenced both operative time and outcomes. Therefore, this study should be regarded as a pilot investigation. Larger prospective studies with at least 12-month follow-up are needed. I would also like to briefly mention Professor Peter Petros. Professor Petros from Australia has been mentoring me for more than 1 year in the field of pelvic floor surgery and integral theory. His guide has been very valuable in understanding the anatomical basis of continence and ligament-based repair. After publication, we also received important expert feedback from him about this midline modification. One important point was that in our technique, the right and left retropubic branches of the pubourethral ligament are approximated and tied at the midline. This may differ from the natural anatomy of the pubourethral ligament. Therefore, this technique should not be considered as a full anatomical reconstruction of the original ULP procedure. Rather, it should be seen as a simplified modification that may provide functional support in selected patients. This feedback was very valuable for us. It highlights the need for better anatomical clarification, technical standardization, and long-term follow-up in future studies. To summarize, midline ULP showed promising early results in this pilot study. At post-operative day 30, 73.9% of the patients had a negative cough stress test. The technique is mesh-free and simple. It avoids tape or mesh implantation and uses a single midline vaginal route. However, patient selection is very important. Older age, higher BMI, and longer operative time were associated with short-term failure. Therefore, this technique should be considered only for carefully selected patients at this stage. The next important question is durability. Larger prospective studies and at least 12 months follow-up are needed before clinical generalization. In conclusion, ULP with a midline approach may present a safe, simple, and mesh-free option, but long-term evidence is essential. I would like to thank you, the organizing committee, for their kind invitation. I also thank you for your attention and for listening to my presentation. It was a great pleasure for me to share our preliminary experience with
First of all, it is a great pleasure to share my presentation about rare surgical emergencies in pregnancy, a case series of ovarian torsion and sigmoid volvulus, a review highlighting diagnostic dilemma. My agenda today: case presentation, discussion, literature review, and take-home message. The first case presentation: a 22 years old pregnant woman, gravida 4, para 2 pre-abortion 1, with history of previous one cesarean section, 29 weeks of gestation, presented to the emergency room complaining of diffuse lower abdominal pain and vomiting since 7 days. Medical history free and surgical history, cesarean delivery and open appendectomy. General examination: the patient was conscious, alert, with vital sign, blood pressure 120/70, temperature 37.8, and pulse 100. Local examination: abdominal examination, generalized moderate distension and tense abdomen. Cervix was dilated 2 centimeters, semi-formed with cephalic presentation of the fetus and intact membrane. Vulva and vagina were free. The initial workup: hemoglobin was 10.7, platelet 279, with elevated white cell count 22 and CRP 214. The ultrasound showed that the fetus was single viable cephalic presentation, 29 weeks of gestation, and normal leg. Patient received antipyretic, antiemetic, and steroid for lung maturation. Antibiotic and investigation were repeated, showed that slightly improvement of white cell count and pus cells were 3 to 5. An urgent general surgery consultation was done, and the recommendation were the following: formal ultrasound abdomen and pelvis, and CT abdomen and pelvis if needed according to the ultrasound finding. Formal ultrasound was ordered and revealed the following: right moderate hydrourethronephrosis with mild free intraperitoneal fluid collection. The patient was fully conscious, with vitally stable on clear fluid, open bowel for flatus, and abdomen was lax, distended, no lower limb edema. For elective CT with IV contrast abdomen and pelvis. However, after consultation, CT with IV was requested, but the mother and her husband refused to perform for fear of teratogenic effect, in spite the gestational age was 29 weeks. So formal ultrasound was repeated, showing the same previous result. Follow-up lab show more or less slightly improved, but the patient complained of diarrhea. The patient was discharged after assuring her about the obstetric condition for follow-up at the general surgery clinic. Patient readmitted again at the Chongqing Maternity University Hospital, complaining of diffuse lower abdominal pain, absolute constipation, persistent vomiting, and fever. The investigation, hemoglobin was 14, white cell count 14, and UST and ALT were accepted. General surgery consultation requested, abdomen distended, rectal examination showed remnant of stool. Urgent CT with IV contrast was done after general surgery consultation with approval of the mother and her husband. The CT showed the following: mild-free intraperitoneal fluid collection. Sigmoid colon was distended, reaching 6.6 centimeter with features of large bowel obstruction versus sigmoid volvulus. So the decision was immediate laparotomy as shown in the CT video. During laparotomy, immediate laparotomy was done via midline exploratory incision. Cesarean section was done by the obstetrician team, and the fetus was viable, admitted to the NICU. Sigmoid colon was gangrenous. Sigmoidal resection with proximal colostomy and Hartmann stoma. Procedure was done with 2 intraperitoneal drain insertion. Intraoperative patient received 1 packed RBCs, 3 fresh frozen plasma, 3-liter crystalloid. Post-operative, the patient was vitally stable. This is a video showing the gangrenous sigmoid colon and the twisted one. And the right video showed cesarean section after done, and the twisted sigmoid colon will be showed now. This is twisted over the pedicle as mentioned. Second case presentation, 34 years old, gravida 1 para 0 at 18 weeks of gestation, presented with a 4-day history of progressively worsening lower abdominal pain, no bowel movement, and multiple episodes of non-bilious vomiting. The pain was sharp, sudden in onset, and localized to the right lower quadrant. There was no history of urinary symptom or vaginal bleeding. Her antenatal course had been unremarkable until this episode. The patient was unbooked case who hadn't received any previous antenatal care. General examination, the patient was toxic and visibly disturbed. Temperature 37.9, pulse 110. Abdominal examination showed marked asymmetric distension, cervix was closed, vulva and vagina were free. A large, dense, and tender mass was palpable in the right iliac fossa extending toward the umbilicus. However, accurately delineating its border from the 18 weeks gravid uterus was clinically challenging due to the patient's severe pain. The initial workup, the patient was anemic, hemoglobin 7.9, hypokalemic, hypoalbuminemic, with metabolic acidosis, and the ultrasound showed a large right adnexal cystic lesion measuring 25 over 15 centimeter with internal echo, and the right ovary was not separately visualized. A large CT showed a large cystic pelvic mass with no sign of appendicitis or free fluid, so the decision was exploratory laparotomy after rapid stabilization. Exploratory laparotomy was done via midline exploratory incision. Intraoperative, the right ovary was found twisted twice around its pedicle, so the torsion cystectomy was done, and the histopathology confirmed an infarcted serous cyst adenoma with no malignancy. However, at 28 weeks of gestation, the patient presented with absent fetal movement and intrauterine fetal demise was confirmed. So this is the incision, midline incision, and in spite of the pregnancy continued till the another 10 weeks. However, intrauterine fetal death occurred at 28 weeks of gestation. So sigmoid volvulus in pregnancy is extremely uncommon non-obstetric complication. Ovarian torsion complicate approximately 3 to 5 per 100,000 pregnancy. To date, only 109 cases have been reported in literature. Bowel obstruction in pregnancy vary from 1 in 1,500 to 166,000 delivery. Sigmoid volvulus affect mainly chronically constipated patient with a long redundant sigmoid colon. High fiber diet is a predisposing factor. Pregnancy increased the incidence of sigmoid volvulus through displacement, compression, and partial obstruction of the sigmoid colon. However, there have been reports of sigmoid volvulus developed in early pregnancy as well as during puberty. Maternal mortality of sigmoid volvulus have been reported to be 500, and fetal mortality up to 30%. The fetal death could be caused by reduction in placental blood flow due to hypovolemia. The use of radiological tool can be useful to establish the diagnosis, but many clinicians are reluctant to use it for fear of complication. It has been recommended that the cumulative radiation dose for fetus during pregnancy should be less than 5 to 10 rads. In general, no single diagnostic study can exceed 5 rads of radiation. Cumulative radiation dose is the primary risk factor for adverse effect, fetal effect, but the fetal age at exposure is also important. Management of intestinal obstruction during pregnancy is generally similar to that in non-pregnant women. The choice depends on the duration of pregnancy and the state of the sigmoid colon. In case of bowel necrosis perforation, surgical exploration is essential. Peritoneal lavage with bowel resection is mandatory. In another hand, diagnosing ovarian torsion during pregnancy remains difficult because symptoms such as abdominal pain, nausea, vomiting overlap with benign gestational complaint. Ultrasound with Doppler flow is the first line tool but carry limited sensitivity. In equivocal cases, we can use MRI due to safety in pregnancy and higher accuracy. The current standard for ovarian torsion in pregnancy is the laparoscopic or open torsion with ovarian preservation whenever possible. As regards the review of literature, for example, as regards sigmoid volvulus, different gestational age present in the review of literature from 18 weeks up to 36 weeks of gestation, duration from the initial symptom up to more than 72, sigmoid colon may be viable and the fetus will be healthy, or gangrenous and the fetus was intrauterine fetal death. Again, duration of symptom and the condition of the mother and fetus may be healthy mother and alive fetus or intrauterine fetal death. Different papers showed sigmoid volvulus during pregnancy, one of them for a pregnant woman at 26 weeks of gestation, another at 24 weeks of gestation, but unfortunately the patient experienced intrauterine fetal death for the fetus, another at 20 weeks of gestation, with different management according to the condition of the sigmoid volvulus. Also, ovarian torsion during pregnancy showed in the different literature review. So my take-home messages: avoid prescribed medication that can mask the symptom and delay the diagnosis. Consider surgical, not only obstetric, causes in each pregnant woman complaining of acute abdomen regardless the gestational age, even if less common. In any case, practitioners need to keep in mind the maternal prognosis is a priority and that the hesitation to obtain radiological examination worsens the prognosis. Common symptoms of sigmoid volvulus include a triad of abdominal pain, distension, and constipation. Good counseling and team management can save lives, not only Peter. If you do not expect the unexpected, you will not recognize it when it arrives. Thank you.
Okay, good afternoon, everyone. I take this opportunity to thank the Scientex conference for giving me an opportunity to present my topic. This was my study, which was conducted as part of my PhD thesis. And the title of the study is Effectiveness of Preoperative Teaching Protocol on Short and Long-Term Post-Operative Outcomes among Women Undergoing Hysterectomy. So when we talk about hysterectomy, it is a surgical removal of the uterus with or without fallopian tubes and ovaries, which is the second most frequently performed major surgery in women worldwide after a cesarean section, which is performed via abdominal, vaginal, laparoscopic or robotic approaches. Approximately 90% of hysterectomies are done for benign indications, which in predominantly for fibroids, DUB, adenomyosis, prolapse, and endometriosis. The concomitant bilateral oophorectomy of cases triggers the surgical menopause instantly. The surgical menopause increases the risk of cardiovascular and osteoporosis, and also studies have proved that though the ovaries are preserved, the women attain the menopause 3.7 years earlier than the hysterectomy. The global statistics have revealed that the rates have from UK, it is 55,000 per year. That is 1 in 5 women by the age of 60 will have had a hysterectomy. In Australia, the statistics is 4.8 per 1,000 women. And Netherlands and Nordic countries, the rates are declining due to uterine sparing alternatives like endometrial ablations and myomectomy. Globally, minimally invasive hysterectomy has rose from 37% to 56% as per the recent data. And WHO in 2022 reported that the laparoscopic hysterectomy associated with fewer complications and shorter hospital stay versus abdominal approach. In Indian statistics, as per the National Family Health Survey, have showed that 1 to 2% of ever married women aged 15 to 45% report hysterectomy, highest in Andhra Pradesh of 5% and Telangana with 4.1%. And the average age at hysterectomy in India has been from 34 to 38 years, which is significantly younger than the global average. And after introducing the government schemes like RSBY and state health insurance schemes linked to rise in private sector hysterectomy rates. And pan-India concern related to rise in hysterectomy is, it's mainly there is increased rates of hysterectomy and lack of informed consent and inadequate preoperative counseling, as reported by Lancet India in 2021. And the significance and the need for the study, the hysterectomy complication rates range from 0.1 to 43% across surgical approaches, and concomitant oophorectomy, which is performed in 50% of cases, precipitates the surgical menopause and increases the risk of cardiovascular diseases and osteoporosis. And psychosexual impact have shown that 60 to 80% of women report significant preoperative anxiety and 20 to 30% report clinical depression before the elective hysterectomy. And the female sexual dysfunction is reported to be in 40 to 60% of women within 6 months post-hysterectomy across the different domains of sexual function, which includes desire, arousal, and orgasm. And also, there are unmet informational needs. The women who undergo hysterectomy consistently report gaps in information about sexual outcomes, hormonal changes, and activity resumptions. And lack of preoperative education also linked to higher postoperative anxiety, pain perception, and longer hospital stay. So based on these findings, there is a need to develop a structured protocol. So existing preoperative education is informal, verbal, and inconsistent, rarely standardized as a validated multi-phase protocol. And at the Indian context, there are no published validated preoperative teaching protocol specifically for hysterectomy women exist in the national nursing literature. So while I gone through the literatures, I noticed lots of gaps in the existing literature related to this hysterectomy. First gap is structured preoperative protocol specific to hysterectomy or scarce, and long-term physiological outcomes are understudied in Indian women. Sexual function follow beyond 6 months is largely absent, and multi-domain quality of life assessment rarely conducted, and the after effect symptom burden, which is usually developed at 4 months of post-surgery, is poorly documented. So the study objectives is to prepare and validate a preoperative teaching protocol for women undergoing hysterectomy, to assess and compare the postoperative outcomes between the samples who received the preoperative teaching protocol with those who received routine hospital care for hysterectomy, and to find the association on post-operative outcome among samples who received preoperative teaching protocol for hysterectomy with their selected demographic variables, and to find the association on post-operative outcome among samples who received routine hospital care for hysterectomy with their selected demographic variables. So the study had a quantitative evaluative approach. The research design was quasi-experimental, non-equivalent control group before and after design, which is also time series design, since this study have assessed both the short-term and long-term post-operative outcomes. And the study was conducted in one of the tertiary level hospital government settings in Salem, Tamil Nadu. And the population were women who undergoing hysterectomy at the selected settings. And the experimental group consisted of 184 patients, and control group had 95 patients. And the sampling, we used non-probability purposive sampling, and the inclusion criteria were women for 30 to 60 years living with partners, those who had a premenopausal and postmenopausal undergone. And the exclusion criteria included those who had a debilitating illness, psychiatric illness, or those who undergo emergency hysterectomy for uncontrolled bleeding, usually happen during postpartum period. So the preoperative teaching protocol, which was developed by the researcher, which was given as a nursing intervention in 3 phases. The first phase was given called as phase 1 preoperative information provided to all patients in the preoperative period, and again this was applied only to the experimental group, which included general information on hysterectomy, preoperative preparations which included on the day before and day of surgery, post-operative exercises which mainly included deep breathing, coughing, leg exercises, and giggle exercises, and incentive spirometric training, which was provided to each patient, and the patients were shown demonstration of how to perform that in the post-operative period, and also the information related to post-operative pain management. Phase 2, which was a home care instruction, which was provided by the researcher at the day of discharge, which included the dietary modifications, the hygienic measures, the general activity, after effects, symptoms, and the home remedies to overcome, and sexuality after hysterectomy, which included the detailed information of the sexual changes after hysterectomy, and also the patients were advised on short-term hormonal replacement therapy, guidance, and its follow-up. And phase 3 consists of post-hysterectomy exercises, which was provided during the follow-up period 2 months after the post-surgery, which was taught about the post-hysterectomy exercises, which included giggle exercises, head lifting exercises, pelvic tilting exercises, and trunk rotation exercises. And apart from that, as this has to be followed by the patients on day-to-day to increase their compliance, an informational booklet including all these informations and the pictorial representation of the exercises step by step was given as an informational booklet to all the patients in the experimental group. And the research tools, mainly I have used all the standardized tools. I have used various tools according to the short-term and long-term post-operative outcomes, beginning from demographic proforma, vital parameters flowchart, numerical visual analog scales, brief pain inventory, STA, that is state and trait anxiety inventory, and Beck depression inventory, sexual function questionnaire, and WHO quality of life, which consist of all 4 domains. Also, the researcher developed tools were used only to test the early and late post-operative complications, and also the after effect symptoms, which were assessed in terms of intensity, the presence as well as its intensity. So the data collection was provided like this. The samples were selected using the purposive sampling technique, and they were divided into control group 100 and experimental group 200. So in this study, as I have used the single setting, the first I completed all the control group patients, then I moved on to the experimental group to avoid any contamination. And preoperative period, the pre-test was conducted, and the routine care was provided to all the control group patients, and the experimental group received the administration of preoperative teaching protocol the day before surgery, and the immediate postoperative period to discharge, I have conducted the post-test. In the coming slides, I'll show you the different variables and how they were measured in the different periods as well. So this is the procedure of data collection. So I collected the demographic data, physiological vital parameters, and other intensity of pain. This was assessed in the pre-test, that is in the preoperative period. Then all the short-term post-operative outcomes, which included physiological vital parameters, which included the vital signs of the patients, and also other parameters mainly focused on the demand for analgesics and their early ambulation and the length of stay, which was tested at the discharge, and the intensity of pain and pain severity scale and pain interference scales. These were used to know the intensity of pain and how they affect the patient's day-to-day living. And the post anxiety, depression, this is also were considered as a pre-test, and also again this was measured at the discharge, again at 4 months after surgery. And the sexual function and the quality of life, which is considered as a long-term post-operative outcome in the study, including anxiety and depression, which was measured in the preoperative period, again at 4 months after surgery. And early post-operative complications, which was assessed through the checklist at the 5th post-operative day and again at discharge. And the late post-operative complications were checked during the follow-up visit at 4 months after surgery, including the after effect symptoms. So I would like to present only the important data related to short-term post-operative outcomes. So the vital capacity, which was significantly higher in experimental group from the post-test to onwards, and this showed the incentive spirometric training proved its effectiveness. And also the experimental group ambulated, which is in the mean of 30.33 hours as compared to control group, which the majority were ambulated in the mean ambulation hours of 41.56 hours. And coming to the analgesics and the length of stay, the study have noted that the demand for extra analgesics was higher on the patients, especially on experiment control group as compared to experimental group, but still it was statistically non-significant, including total analgesic doses. And the length of hospital stay found to be higher, which was 17.65 days in experimental group as compared to control group, which is 14.31 days, which showed a statistical significance. This is mainly due to, as the study was conducted in the government settings, the patient's preference was given at the time of discharge. So the patient wanted to go home only after they fully recovered. So that is the reason the experimental group, as they were given lots of information in the periodical way as per the protocol, they stayed in the hospital 3 days more than compared to the control group. And as I said, the ambulation was more earlier in experimental group as compared to the control group. And coming to the early post-operative complication, it was noted that the constipation and urinary tract infection, these two complications were found to be more in control group as compared to the experimental group. And the intensity of pain, again, you could see that the trend experimental group had significantly lower pain severity score, and also the pain interference scores also was less in the experimental group. So that they had a less pain interference, which does not affect their day-to-day activities, including their mood, sleep, and the social activities. And coming to the anxiety scores, which was tested at the pre-test, which was just before the surgery, and the post-test one, which was done at discharge, and post-test 2, which was done 4 months after surgery, you could see the rapid decline of anxiety score and the depression scores in the experimental group as compared to the control group. So this is mainly due to the patients was provided timely information, adequate information, so that helped them to reduce their anxiety and also reduce their depression status. And long-term post-operative outcome from my study was All the key findings, mainly all domains declined post-surgery in both the groups, and no statistically significant difference between experimental and control group or on between group comparison. And within group comparison, both experimental group and the control group showed significant decline from pre-test to post-test. And this study have showed that the female sexual dysfunction rates increased post-hysterectomy in both groups, and also the pain domain, which had the control group, had higher pain scores as compared to the experimental group. And coming to the quality of life outcomes, it was showed that the physical health improved in both groups from poor to moderate because they got relieved from the symptoms as the uterus was removed, and no significant intergroup difference were observed. And psychological status, again, experimental group significantly better than the control group, and social relationships also improved, and environment status also were improved in experimental group. Overall, the quality of life score showed that the experimental group had the 239.58 compared to control group 222.65, which had a statistically significance. And preoperative teaching significantly improved the psychological, social, and environmental domains under the quality of life. And the physical after effects symptoms, mainly it was noted that the sleep disturbance and the fatigue, these were more in the control group as compared to the experimental group. Though the lack of libido was observed in the study, it was showed that the experimental group had more lack of libido as compared to the control group. And psychological after effects, it has showed that the mood changes and especially the feeling guilty, this was found to be more among experimental group as compared to the control group, because they came to know what were the different after effect symptoms which is mostly observed after hysterectomy through the informational needs. So again, this is the repetition of the key study findings. So coming to the implications and recommendations for the study, nursing practice, the preoperative teaching protocol should be mandatory in all gynecological settings, and there should be a multi-phase approach of giving the informations in a timely manner at the preoperative period, discharge, and at the home visit ensures the continuity of care. And lifestyle modification counseling, including sexuality, must be routinely included. And integrating this to the nursing education, integrate structured preoperative education into curriculum for gynecological nursing courses, and simulation-based training for nurses in incentive spirometry and exercise teaching specific to hysterectomy has to be focused, and including the PLST model training, which is one of the famous model which is used to give a psychosexual counseling, which consists of 4-tier model, which includes permissions, limited information, specific suggestions, and intensive training in certain areas. So this found to be more, even now recent evidence have shown that the patients who are given psychosexual counseling earlier in the hysterectomy, they had better understanding of their post-hysterectomy sexual life. And recommendations from my study finding, follow-up studies on sexual function and after effects should be continued even at 1 year post-surgery, and there can be more comparative studies comparing between private versus government settings, and also comparing the different approaches of hysterectomy, including abdominal versus laparoscopic approach, and longitudinal study on cardiovascular health and bone density on post-hysterectomy cases, and community-based mass awareness to prevent unnecessary early hysterectomy. Thank you.
Good morning to all of you. I'm Dr. Molly Nandi, and I'm speaking from Luton and Dunstable Hospital, United Kingdom. So this was a quality improvement project that I did in my trust, whereby I had formulated a structured history-taking proforma for menopause, and the intention was to complete the history and the consultation time quickly and ensure patient satisfaction is improved. So the background of my quality improvement project was menopause consultations were time-consuming with inconsistent history taking, delays in addressing concerns, and longer patient waiting times. The aims and objectives. The aim was to develop a comprehensive clinic pro forma with a standardized questionnaire to enhance assessment, diagnosis, management of menopausal health, ensuring consistent and patient care. I wanted to create a structured pro forma to ensure that all the key aspects of menopause care are addressed, as often there are registrars from or consultants from different backgrounds of gynecology who conduct the clinic, and sometimes due to the in rush hours, if there are too many patients, some key questions may be missed by the patient or the consultant as well. Provide clinician with an easy to use tool that reduces consultation time while maintaining thoroughness and providing a clear management pathway. The duration of this quality improvement project was from 1st of January 2025 to 31st of October 2025. We implemented this standardized pre-consultation questionnaire plus a structured clinician pro forma. So patients completed the questionnaire while waiting in the waiting room. This supports clinician decision making using British Menopause Society guidance on embedded bleeding with HRT. Includes patient education, QR resource section, because there's a QR code at the back of these questionnaires as well, where all the patient information leaflets can be accessed by just scanning it. Improves the workflow, reduces consultation delays, and enhances patient understanding. The baseline, the pre-intervention, it was in the setup of our gynecology outpatient menopause clinic. The criteria we measured were average consultation time, which was around 23 minutes. Average time spent on history taking 14 minutes. More than 80% of the history completedness was only 44%. Red flag documentation only 50%. QR or patient resources which were dispensed with 30%. Lifestyle advice documented 38%. Patient education provided to the standards of being very good was 38%. Patient satisfaction as per our survey was only 46%. Waiting time was perceived too long by 40% of the patients. Clinicians' efficiency was good or very good at 28%. So the outcome measures were primarily reduce consultation time, improve completeness of the history taking. Secondary was to improve clinician satisfaction, patient education, reduced missed red flags, patient completion of pre-consultation questionnaire, clinician uptake of structured pro forma, and balancing impact on patient waiting time and patient acceptability. The structured pro forma, as you can see, I have highlighted on section 6. So it has all the key points in systematic manner, including the patient details at the beginning with the clinician signature at the end. And at the back of these questionnaires, there are all the QR codes which the patients can scan and save all the patient information leaflets, because a lot of information is given during the consultation which the patients don't remember. Bless them. So we have provided with these resources so that they can go back home. Sometimes they need to have a discussion with their partners or their family members about some medications, and sometimes it's a tricky situation. So we give them time to think on those lines and then make an informed decision. As you can see, this slide, the section 7 has the post-intervention results, whereby the average consultation time was 18 minutes. I would rather move to the section 8. We can see the improvement before and after. The consultation time was reduced from 14.2 to 9.1 minutes. History taking time to 6 minutes. Completeness of the procedure 86%, whereby earlier only 44%, there was more than 80% completion. Red flag documentation increased to 100%, which is very, very important, because even missing out one red flag can have catastrophic consequences. Patient education perceived very good as per the patient survey, 74%. Clinician efficiency as described by the patients increased from 28 to 76%. And the waiting time, which was perceived as long, reduced from 40% to 22%, which was a good outcome. So the plan, do, check, act cycle, which we usually follow in any QIP, we identified the problem, baseline measures, designed the intervention. The intervention here was the structured menopausal pro forma. what we did was implementing the pre-consultation questionnaire and structured proforma, staff engagement, and the pilot phase study afterwards and before. Compare the pre and post outcome, analyze the results. Now we are continuing to implement this proforma in the clinic, refine and sustain intervention. We have educated the staff on the various aspects of menopausal care as well, digitalization and repeat audit with a larger sample, which we are intending to do again. We have already done the re-audit, but we want to do it on a larger sample as well. So what are the lessons that we learned? Improved understanding of menopause and treatment options, because one shoe doesn't fit everyone. So we have to customize the treatment as per the patient. Better consistency and completeness of menopause history taking. Reduce time spent on history taking. Improve clinician confidence and efficiency. Better guidance and safety. What we could have improved more on this: increase questionnaire completion rates, improve consistency of proforma use across all clinicians, because not all of them are doing menopausal clinics every time. So sometimes there is some lacuna in completing these proformas as well, for which we are doing ongoing training. Provide full staff induction and training. Consider digitalization. So we are considering that instead of doing the paper proforma, we will be moving to the digital format so that it can be stored in the system as well. There's a less chance of getting the question proformas lost as well. And then we don't miss out on any of the questions. The limitation of the study was the sample size was small because of the fewer women actually coming to the menopausal clinic. Short data collection duration, busy clinics affecting the full implementation, variable staff compliance due to workload and rotation. How we want to make it sustainable: embed the structured proforma into routine gynae outpatient clinic practice, because sometimes these menopausal patients do not come to dedicated menopause clinics only. They come to other clinics like the urogynae clinics, general gynae outpatient clinic, and the onco clinic as well. Maintain period proforma use in consultation rooms. Include the proforma in departmental induction. Nominate a clinical lead for oversight. Conduct larger PDCA cycle. In the end, I would like to state this QIP addressed inefficiencies and inconsistency in menopause consultations. A structured pre-consultation questionnaire and standardized proforma improve workflow and documentation quality. Results demonstrated reduced consultation time, improved completedness of menopause history and red flag documentation, enhanced patient understanding and satisfaction, and increased clinician satisfaction. The intervention was feasible, low cost, and sustainable in routine clinical practice. With continuous use and scale up, it has the potential to standardize menopause care and improve patient outcomes. Thank you all of you for your patient listening and for giving me this opportunity to present my QIP.